Hello, my friends. My name is Jill Osborne. I'm the National Interstitial Cystitis and Pelvic Pain and Bladder Pain Support Group Leader. It is Sunday, October 11th, and stunningly, I'm here. Our house didn't burn down 2 weeks ago. Let me tell you, you would not have want to been in my neighborhood two weeks ago. So the purpose of my doing this support group, oh, look at this. Okay. See, I'm just getting back. The purpose in doing these support group meetings is to make you so strong, so knowledgeable, so informed that no one can ever mess with you again. I don't want anybody to tell you that this is all in your head. I don't want anybody to tell you that there's no treatment. I don't want anybody to tell you no hope. I don't want anybody to tell you, that you have severe pain for the rest of your life, because that is simply not true. If you were an IC patient from 30 years ago, I'm telling you right now, you got to throw out everything you learned 30 years ago, because none of it's relevant now. We no longer think of IC as an incurable bladder disease. We think of IC as a pelvic pain syndrome. Why? Because there are structures outside of the bladder that are often causing symptoms, right? So, I normally do these meetings every Sunday. It's always hard during fire season. And unfortunately, we had a really good meeting 2 weeks ago, 5 hours long. We finished. I was exhausted. I made dinner. I sat down. I was ready to rest when I got an emergency alert over my phone that a new fire had started right over my hill. And not only that it was 8 miles away, and they predicted that within 2 hours, it would have burned all the way into my city. Well, so I immediately started packing my stuff, because I have to pack up the entire IC network. So it's like, all right, pick which computer I'm going to bring, or both computers, get my stuff ready to go, all the checkbooks, all the insurance, everything. And then have to go round up the rest of the family and say, all right, Dad, there's a new fire. Start packing. He goes, no, that's a fire over in Napa. We're fine. It's like, no, Dad, it's a new fire, right? So we're getting everybody geared up. An hour passes. And I've got the car backed into the driveway, and I'm already loading up all my stuff and all my business stuff and my personal stuff. And I look up at the hills, and there's a red glow. I've lived here my entire life. Never seen these hills lit up with a red glow. 5 minutes later, flames at the base of the hill. See, I live on the only hillside that had never burned in 100 years, because we thought with the wind dynamics, any north to south winds, because of the height of the hill, would push the winds away. But this fire started at an angle. And so it came kind of from the northeast instead of from the northwest. So anyway, so I'm out there and I'm going, Holy Mary, Mother of God. 5 minutes later, I see flames at the base of trees. I go in, I get my dad. Dad, look. He goes, uh-oh. Go round up my neighbors. We're knocking on everybody's doors, making sure everybody knows there's a fire coming. 10 minutes later, 100-foot flames. 100-foot flames right on my hill. You guys, if you could see out this window, and I know you can't because of the glare, I am just one parallel street away from a beautiful hillside. So this was not far. This was maybe a half a mile away. So like I'm running back in the house. My dad wants to pack up his guns. It's like, all right, we go downstairs and get his guns. My mother needs her meds. I'm getting everybody going, yada, yada, yada. I go back out the next time. The flames are coming down the hill 5 minutes later. As we left at 1 in the morning, the flames were almost to our house, and we drove away sobbing, thinking that we had lost our house. What we didn't know is that there was a stalwart bulldozer operator who at that moment was burning a fire break immediately 3 houses away. The fire got 3 houses away from my house. A bulldozer operator saved my little neighborhood. So, hallelujah. We have reason to celebrate. I have a home. The future is scary. I don't know what we're going to do in the future, but it is what it is. All right. So thank you for listening to my little fire story, because I, as a support group leader, need support just like you guys do. And it is, you know what, I got to tell you, I was solid. I got us packed. I got us evacuated. I got 2 90-year-olds out in their cars. I, got everything set up where we were staying. I got everybody back 4 days later. I spent 2 days cleaning the house. Man, I had an infinite source of energy until like 4 days ago. And then I crashed and burned and had to lay on the couch for 2 days. So anyway, so the way I do these meetings, let me introduce myself. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the longest serving. Oh, I don't know. Okay, gosh, I did that whole thing. You might not have heard me very well. That was not very good. So I'm the longest serving IC support group leader in the United States at 27 years. Last month, I sat on the U.S. Army IC research panel for many years. I bring to you 3 college degrees, a degree in chemistry, a degree in pharmacology, drug development, and then because I did not like the animal work and the lab work that was being done, I switched to psychology. The IC Network was my doctoral dissertation proposal in how to bring support to patients who were homebound. Because I was at the time homebound because IC struck me at the age of about 32. Ironically, couldn't do the degree. Got my master's, couldn't do the PhD because it hurt too much to sit in the car. However, I'm very happy that 27 years later, the IC Network is still rated #1 in the world by Harvard Medical School and the University of London for the accuracy, reliability, and credibility that you will find on IC. So whenever you are looking for information on interstitial cystitis, please come on over to icnetwork.org. Now, I normally do these meetings in 3 sections. I do a little bit of a lecture first, then I'm going to take your questions, and we're going to switch into a Zoom meeting so that you can ask me questions, and then we will go back. I don't know how long this is going to be today. It might be 3 hours. It might be 5 hours. We'll see how it goes. We'll see how long I last. Obviously, the last 2 weeks have been very, very stressful for us. But I want to start by talking about central sensitization. Okay, so we know that there are variants in IC, right? I mean, we know that. That's a given. We know that for some of you, IC begins in childhood. For others, IC begins after menopause. Are you the same? Oh, hell no, you're not the same. We know that for some of you, IC begins after having a baby. We know for others, IC begins after chemotherapy. Are you the same? No. Interstitial cystitis is essentially a grab bag diagnosis. If they don't know what's wrong with you, they will often say that you have IC. And the other thing that we know very clearly is a one treatment approach fits all does not work. The Elmeron bladder therapies do not work for the vast majority of patients out there. Okay, why? Why? Because for many of you, there is there are sometimes structures outside of the bladder that are the problem, that are victimizing your bladder, that they are triggering frequency, urgency, pressure, pain. As an example, if you have a Tarlov cyst coming off of your spinal cord around L5 that's pushing on the nerves that innervate your bladder in this area, that could explain why you have frequency, urgency. If you have a fibroid tumor pushing on your bladder, that could cause frequency, urgency. And we know that because what research has shown for those patients is if they remove the fibroid tumor and they remove the pressure on the bladder, the frequency, urgency usually goes away. Then there's a really, really interesting study that happened that was released, I'm going to say like 6 weeks ago. And it was about men with testicular pain. So men with really severe scrotal pain or testicular pain. And what they found in that study is that 70% of those men had an underlying hip abnormality. So you have to understand that the pelvis is a very small confined structure in your body that has a lot of things going on. I mean, you got muscle, you got bone, you got organs, you got blood vessels, you got nerves. And because they are so closely confined, they will absolutely influence each other. All right. So for the next 3 weekends, I am participating in the International Pelvic Pain Society annual meeting. And this weekend is the pre-course in pelvic pain. So I woke up at 6 in the morning yesterday. I got to say, that was pretty good for me since I haven't been sleeping well, and attended their class on their basic fundamental class on chronic pelvic pain. And holy moly, is it very, very different than what it used to be. And they emphasize and they talk about the influence of all of these structures. So the case that they gave throughout this entire 2-day course is as a woman who in her 20s developed endometriosis. And she had painful periods from endometriosis, right? And she had some, it was obviously part of a problem for her. And then in her 30s, she developed vulvodynia. And then in her 40s, she developed irritable bowel. And then in her 50s, she had a whole cake of pelvic pain disorders because she then started having bladder symptoms. So why would that happen? Now, I'm one of those patients where when I had vulvodynia in high school. Okay. I had irritable bowel when I was in my 20s. I developed IC in my 30s. And for many of you watching this, I know that you're baffled and confused about your body. It's like, what the hell is going to happen next? I mean, like, seriously, it's like every 2 years, what else is going to happen to this crazy body? That's how I felt in my 20s, and I wasn't even having bladder issues then. So what they talked about, and you know what, let me just grab my notes here real quick. Where did I put, are these my notes right here? Yeah, here it is. So what they talked about was maladaptive pain. So maladaptive pain is when there is a malfunction of normal nerves. And this is really complex, and I want to try to say this in the simplest way. I'm going to do a big article on this in our next magazine. How advanced do I want to go here? A nociceptor. Okay, you guys remember this. Okay, for those of you watching, I do giveaways. I do giveaways at almost every meeting. I'm telling you right now what my question is going to be. Remember the word nociceptor, Nociceptor. Okay, nociceptor. A nociceptor is basically a normal nerve that's driving something functional, like moving your arm. There's nociception happening. And these are, God, you guys, I apologize for this being so complex. Nociceptive pain so it's like from heat, from cold, if you're injured, if you're hit, if you have a chemical exposure, that goes via a nociceptor sensory neuron to the spinal cord to the brain. Sorry. Okay. It is what it is. But when that nerve is injured, it drives a reorganization process that the nerves in the peripheral tissues, like in your bladder wall or in your skin, can become more easy to turn on, right? Less is more. So people with central sensitization, we have very sensitive skin, and that a normal touch can be painful. I went through a period, I'm going to say like a year or two after my IC started, where I had really bad pain. And just know, guys, I don't have pain anymore. I'm healed. I'm very, very healed. There's hope. When those nerves are driving, and they're firing and firing, and you're in terrible pain, what happens is that the nerves become more sensitive. They just do. And so there's something called allodynia. And allodynia means that the nerves in the area also become sensitive. So I went through a period of time where, you couldn't touch me from the, from my tummy. Oh gosh, come on. Okay, from my waist down. You couldn't touch me there without, even the softest touch, my belly button. Oh God. Okay, my belly button. You couldn't touch me from my belly button down. Even the softest touch provoked pain. That is an example of a nerve that has changed because of pain that is intense and potentially not treated. It should have been treated perhaps earlier. But we also know that not only do the peripheral nerves change, but potentially the spinal cord nerves change. And so some of you have had your bladder removed, only to discover after the fact you still have pain. Okay, and that can be for two reasons. Number one, because your pain was never from your bladder in the first place. Or number two, your spine has adapted to and has been traumatized and has reorganized because of the pain. And so can your brain. Your brain is kind of like a thunderstorm. You know how if you're watching a good thunderstorm, it's like the cloud here lights up and the cloud back here lights up and the cloud in front. That's how your brain functions during periods of pain, is that lots and lots of areas of your brain start to light up. And so in this class from the International Pelvic Pain Society, um, they were talking and really emphasizing that the difference between a single event, acute pain, like a really, really bad bladder infection, but then it goes away and everything calms down, as compared to chronic pain, where pain is lasting for a longer period of time, is the result of these nerves that are changing in the presence of pain. Now, and this is where some of you and this is where we make mistakes, because some of you just literally won't do anything until you're screaming in pain. Like, you won't do anything. Like, literally, you have a little prescription of Norco and you refuse to use it, and because you don't want to be seen as a drug abuser, and you won't do anything until you are literally bawling your eyes out in agony. And that's a problem, because the earlier you catch pain, the more quickly you can stop more nerves from becoming involved. Donna says, "This is what I have, Jill, allodynia. I used to be that way, Jill, with Norco." And that was kind of, I think, one of the reasons why I did fairly well is because of my pharmacology degree. Even though I had no pain care my first 2 years, and I'm telling you guys, my pain was insane. I couldn't sleep at night. I had so much damage to my bladder. Of course, I was drinking cranberry juice every day, not having a clue that was driving the pain. But when they finally gave me a Vicodin at that time, it was like a miracle. It's like, wait, what? You you can turn this pain off? I don't know why. I didn't think that pain medicine would be relevant to extreme bladder symptoms, but in my brain, I was thinking cranberry juice. You're all thinking cranberry juice and all stuff like that. And so when they finally gave me a little bit of Vicodin, what I learned is if I caught my pain very, very early, like within the first hour, and I gave myself permission to take a quarter of a Vicodin, I could stop 90% of my flares. I could stop them. And of course, that's hard today because you were not given pain meds like we used to be. And that's a tragedy because visceral pain, bladder pain is intense pain. And so we have to be incredibly, incredibly, incredibly attentive and intuitive to things that trigger pain. Now, I am living proof that you can go from having the worst nerve pain imaginable to being pain-free. Because I haven't had that severe pain in 15 years, maybe. Every now and then I have a little flare, but I can totally nip it in the bud. Things have changed. I mean, I've gotten older, things have changed. And if you looked at my bladder's completely healed. But the question is like, again, kind of getting back to this patient who had endometriosis, and then she had vulvodynia, and then she had IBS, and then she had IC. What the hell is driving that? And the answer comes right back to nerves, sensitive nerves, central sensitization. IC subtype 5 using the Chris Payne subtyping system. So what doctors are doing now around the world is that they are trying to understand your unique presentation of IC so that we can give you the right treatments for your unique presentation of IC. So if you have subtype number 1, Hunner's lesions, we're going to be doing lesion therapy for you. If you've got subtype 2, bladder wall driven, we have to figure out why. You might have estrogen atrophy, and that might be driving your bladder sensitivity. You might have a chemical injury. You might still be drinking way too much coffee or soda. Guys, seriously, the bladder can be injured like any other part of any other part of the body. The bladder can and will be injured, and it is normally injured with chemicals. And your bladder was not built to handle acid all day, unless your family is from the equator. I mean, if you're northern Norwegian like I am, believe me, my bladder does not have a lot of defenses for lots of acid, right? So there's some evolutionary things happening. Some of you might have chronic fungal infection or chronic viral infection. When you think about bladder infection, everybody thinks bacteria. But guess what? We have now proof from our own U.S. National Institutes of Health MAP Research Network that many IC patients who are flaring because they have candida in their bladder, in their urine. A candida infection. And think about all of you who have saved your antibiotics and they're sitting in your bedside table, just like mine are sitting in my bedside table. And the minute you have a flare, what do? You take an antibiotic. And what you don't know is when you're taking the antibiotics all the time, you're creating an environment for fungus to grow. And so next generation urine test will help us identify that. IC subtype 3, or actually technically bladder pain syndrome subtype 3, is a muscle injury. It's the biggest subtype. So these are the patients whose symptoms began after a fall or a car accident. If you flare after having sex, that's a muscle flare. If you flare when you're driving in a car, that's a muscle flare. If your muscles are spasming and your muscles are tight, your bladder is going to feel it. You're going to have frequency, urgency, pressure pain. IC subtype 4, or bladder pain subtype 4, is pudendal neuralgia. So it's a nerve injury. So think about it. We've gone from a bladder wall injury, potentially chemical injury, then we're dealing with a muscle injury, and then our fourth subtype is a nerve injury. So if you have symptoms when you sit down, you have shooting pain, sciatica down your leg, if you feel like you're being shocked, if you have persistent genital arousal disorder, where you're feeling this kind of awkward, icky, awful, aroused pain sensation, that means that your pudendal nerve is being compromised in some way, usually by tight muscle. So for these patients therapeutically, we're going to try to figure out where the nerve is compromised, and we're going to try to calm those nerves down. And obviously physical therapy if muscles are the problem. But it's the last subtype, central sensitization that really the International Pelvic Pain Society is really focusing on. And as I've said in past meetings, for some of us it's genetic. And in fact, I asked that question and they didn't answer that question. But of the speakers, of the three speakers yesterday morning, I know in my case, every woman in my family has sensitive skin, a sensitive bladder, a sensitive bowel, going back generations. Hello, redhead. Any redheads know, and the research proves we have, not only do we have more nerves than you guys do, but our nerves are just more sensitive. They're easier to turn on. It's the landscape. It's how I'm wired. There's no shame in it. There's not a disease. It's just anatomy. It's the anatomy of being a redhead or somebody of a Northern European descent. We tend to be more sensitive. But central sensitization also occurs after injury. And that's really the context of why that young endometriosis patient ended up developing other pelvic pain and chronic pain conditions, is that at that period of time, her endometriosis in all likelihood, now granted, this is just a case study, it's not a real patient, but I'm going to fill in the blanks since I've worked with so many patients. So this is a scenario that I think would probably happen. So here you've got a patient with endometriosis with very severe pelvic pain from the endo every month, right? So every month when she has her period, the nerves get wired up and then hopefully they calm down. And the doctors at that point in time, let's just say that it was 25, 30 years ago, you just got to learn to live with it. You don't need pain meds. Come on, it can only last a couple of days before your period. Not understanding the toll that repeated pain exposure is potentially playing to the nervous system. And then we get some allodynia. We start getting some nearby nerves getting sensitive. So all of a sudden, we've got vulvodynia. So now, in addition to the endo pain, she feels like she has a yeast infection. She goes to the doctor. It's like, Doc, I have to have a yeast infection. It hurts so bad down there, especially on my perineum. And the doc takes the look and goes, well, you look normal, my friend. You look normal. And here you are. You're just buying stuff. Man, you're buying every yeast medication you could possibly buy. You should have stock in Monistat. And sometimes it helps and sometimes it doesn't help. And your doctor is baffled. My doctor said to me when I was in high school, you have the most sensitive skin I've ever seen in my life. And then, so now we have two sources of pain. We got the pain from the endo, and now we got the vulvodynia pain. So now we got two sources prodding at the spinal cord, right? Ow, 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 ow. And of course, the spinal cord and the brain and your nerves are going to react to that pain. So then all of a sudden, you get rectal pain. Or you get irritable bowel syndrome. And it's like, what the hell is this? Why are the nerves in my bowels so sensitive? You eat a salad and 30 minutes later, you've got explosive diarrhea. Where the hell did this come from? And then, of course, you go have the workup. They do a colonoscopy. They rule out cancer. They say, yeah, you know what? You just have chronic IBS. You got to eat fiber. And now we have three sources of pain hitting the spinal cord and the brain. So then one day you wake up, oh my God, I think I have a bladder infection. You go to the doctor. Doctor, oh my God, I couldn't sleep last night. I was up every hour. I think I have a bladder infection. They do a urine culture. It's negative. You're baffled. But they give you antibiotics anyway. And maybe a couple days later, you get better. Was it the antibiotics that made you better? Or did the nerves just calm down? But then a month later, it happens again. You call the doctor. Doc, it's back. I got another infection. Please help me. Oh my God, it hurts so bad. You go leave a urine culture. It's negative. And they tell you you have interstitial cystitis. Or they might say you have overactive bladder. And then you're down this rabbit hole of quote unquote IC. And so imagine being this patient. You know you have endometriosis. Your periods are still painful. You're basically praying just for menopause. You know you have vulvodynia because you can't wear jeans and underwear. You know you have IBS. You're afraid to go out and eat now because you're afraid that if you're with your friends or out on a date and you eat a salad and you have explosive diarrhea, well, there goes the date. Hey, it happened to me. You know? Took me a while to figure out it was the salads that was doing it. And then the IC happens. And then you're stuck doing bladder stuff too. And so what's exciting about what we're seeing now is that number one, for that early patient, we understand the consequences of untreated pain. We understand the consequences of that. So now for that endometriosis patient in their 20s, we want to be all over that. We want to really be trying to treating that as aggressively as we can. But we also know with chronic pain management, let's go to that patient in her 40s. So she's got endo, she's got IC, she's got all the things. So she's got lots of things firing. And we know that the secret is reducing the volume of the overall pain on the spinal cord and on your brain. And so today for the central sensitization patient, and that's a lot of us, we don't want to leave something firing. So let's say we got the endo under control. You had the surgery for that. We got the vulvodynia under control because maybe you're using lidocaine and something else, but the IBS is still raging and you're doing nothing for the IBS because you're too afraid to talk about it with your doctor. As long as there's a nerve bundle firing, that your nervous system is going to stay in distress. And so our collective goal here is to try to find any pain generator and reduce the volume. That when we reduce the volume of pain transmission, the nerves start to calm down. So for those of you who have abandoned physical therapy because it hurt too much, and you're only doing bladder treatments, you're missing the point. If your muscles are screwed up and causing pain, that's where we need to be focusing on time. We've got to get the muscles to calm down. I don't know. I'm sorry. Cause and effect. Cause and effect. Cause versus symptom management. Yes, yes, yes. Having pelvic floor physical therapy can hurt. But the goal here is to fix it so it stops hurting altogether. Because if you don't, it's always going to be hurting. It's always going to be a tension pattern. Every time you try to have sex and you've got tight muscles, it's going to hurt. So we have to try to address fundamental causes for all of those conditions. And I know I kind of contradicted myself because it's like I'm saying, well, let's make sure that we're not turning pain nerves on. And that's true. But sometimes you have to do that to fix the fundamental problem. Gosh, I really hope that made sense. The other thing that they talked about in this class yesterday is that when pain sensations from your bladder and from your pelvis go up to your spine, they hit your lower spine, they go up your spine, they go up into your brain. And you're thinking like it's just it starts and begins. Like there's like a beginning and an ending, that the nerve starts in one space and ends in another space. And that it's a very simple pain process. And what they said is that that's just not true. That the brain itself is remarkably complex, and that there are whoops, hold on. It would be nice if I used the right mouse. Pain meets a complex brain. And God, and you know what? I don't want to shoot. I don't want to say this. Now, listen, I'm not being all touchy-feely here. I'm not giving you weird pseudoscience. You have to understand that your brain and how your brain performs is influenced by your state of mind and your health, right? It's influenced by your relationships in your heart. It's influenced by your mind, right? If you're struggling with anxiety, that's going to intensify pain. If you are in a more joyful place, your brain will minimize pain, and that's pretty proven. Your brain is influenced by your physical health. It's influenced by your body. It needs good blood flow. It needs all sorts of good things going on. So we've got to try to be healthy physically. And it's influenced by your spirit. The more a patient feels safe and secure in your daily life, the calmer your brain will be in the presence of pain. Think about it. Think about it. The more you feel safe, the more you feel secure, the more you feel comfort, the more you feel tranquility, calmness. You calm your brain in the presence of pain. And remember when I said the brain is like a thunderstorm, like light, it lights up here and here, it just lights up all over the place. But when you're calmer, it doesn't light up as much. Another thing is keeping your brain busy. That if you keep portions of your brain busy, that area of your brain cannot light up. As Donna says, our bodies are very synergetic. The body has to be in balance, mind, body, and spirit. We need to be more connected. And so that's important for us to understand, that your state of mind is going to interpret and it's going to influence how you're processing pain. And that's really hard right now in 2020. We have a hell of a lot going on. It's really, really, really important that we all take a step back and give our brains a little bit of comfort and joy. I started doing my affirmations again. I mean, seriously, I ran for my life 2 weeks ago from a fire. You want to talk catastrophizing? My brain has been out there for the last 2 weeks, and I dawned on me as I was listening to this lecture yesterday, Jill, oh my God, you have to start doing your affirmations again. We've got to calm things down. So that was just and you know, it's really interesting. Is they even talked about, so when you're working with a chronic pain patient, an important part of that is obviously just trying to get your brain calm again, trying to just figure out if there's anything that's amplifying it for any reason. Is there anything jabbing you over and over and over, right? That's just bugging you, whether it's somebody in your life who's diminishing you and minimizing you and telling you that it's not real and all that sort of stuff. But one of the things that Alexander Millspaw said, she was the speaker on this portion, is that when she works with patients who are really struggling, they try to go back all the way to the beginning. And that even a birth experience can change our nervous system and make you potentially more vulnerable to uh, um, central sensitization. That a newborn in the ICU can change nerves if they're not getting that mother's love and that mother's kind, the whole maternal bonding, safety, security of being held and loved by somebody, by your mom or your father, that they're even able to kind of go all the way back and look at an early childhood event that would have set the foundation for central sensitization. And the other thing that she talked about was bullying. That people who are bullied when you're that in childhood, that also creates a little bit of a windup of the nervous system. And I know I went through a very, very severe bullying period when I was in elementary school. And I've always believed that has played a role in me today, because it's always a part of me. I was just talking about it to my mom last night. It's like, it's kind of like, God, I encounter bullies wherever I go. I feel like I'm like the poster child for fighting bullies, because I don't take it anymore. But I did take it when I was a kid, but I just don't take it now. If you're a bully, come on, bring it. I'll deal with it. Because I know a bully is nothing about me. It's everything about the bully. I don't take any of that personally anymore. But when you're a child and you don't have those defenses, that also can kind of wind up your nervous system. And so can the quality of your sleep. If you're not sleeping well, that also can wind it up. So therapeutically now, let me just kind of end this portion. Injuries happen. A pelvic injury happens. It's the legacy of that injury, the legacy of that untreated pain, the legacy of tight muscles that have not been addressed, that can create the foundation for other things to start happening in your pelvis. And so if you are newly diagnosed and watching this, you are an anatomical mystery to be solved. Before we can talk about any therapies, we got to figure out what the hell happened to you. What happened? What was the original trauma? And we want to address that. We don't want to leave that unaddressed. So if you fell on your tailbone and you broke your tailbone, and your tailbone is out of position, that helps us understand why your muscles are messed up. If you had a baby and you were your muscles were torn, that helps us understand. If you had chemotherapy and the chemotherapy irritated your bladder wall, okay, that's the original injury. And so it's very exciting. And I want you to see in me that when I had a doctor say to me, "You will forever be in pain. This is your life. Get used to it." I said, "I will prove you wrong, you son of a bitch. How dare you say that to me?" He told me I would be a burden on my family. Well, ooh, I almost said the F word. What's a good word to say instead of the F word? Okay, anyway, screw him. And that's what I said, except I actually said the F word to him. I will prove you wrong. How dare you say that to me? And it was at that moment that I started fighting. And it was at that moment that I started learning. And it was at that moment that I started reading. And it was at that moment that I started trying. And it was at that moment that I took the diet seriously. I did not want to live with pain. And there's one thing you can count on, is that healing is always happening. Healing is always happening. Your body is trying to fix whatever the hell happened to you. Nerves calm down. My nerves calm down. It is possible. but it begins with understanding your anatomy. We have to figure out what happened. And this, if frog you, Brooke says frog you. So this is where social media can mess you up, because I was working with a patient on Friday who's just like living on Facebook in an IC group, and she's just like believing everything they're saying. She's like doing everything, doing D-mannose, she's doing this, she's doing that, she's doing supplements, yada yada yada, and it wasn't her bladder at all. It was her pelvic floor. And she had a very clear injury to her pelvic floor. And nobody ever told her about that her pelvic floor could cause the issues. All right. So, okay. So I hope I didn't botch that. It's a very academic topic. The moral of the story is, if you have pain, let's try to treat it and catch it as early as possible. If you're having an IC flare, nip it in the bud. Don't freaking wait until you're crying to do something about it. As soon as you feel something weird, if you drank that cup of coffee and 30 minutes later your bladder's feeling a little funky, for God's sake, drink a glass of water and dilute that coffee, right? Or take some pre-leaf to alkalinize that. If your IC flare began because you had sex, then take a hot bath, put a heating pad on. Let's try to relax those muscles. If your IC flare is a result of intense stress, then let's take a step back. Let's breathe it in. Let's calm and collect it and try to reduce that stress level. And we will do that. Kathy says, what test for estrogen should my pelvic floor therapist? You know what, Kathy, it's really, yeah, they can do a blood test, but ultimately it's just eyeballs on your vulva. They can see estrogen atrophy on your skin. Your skin gets thin. Listen, if you're over the age of 40, then there you go. You got, for women, your skin is going to change. It's going to start changing. It is what it is. It's not a disease. It's estrogen atrophy. And at some point in time, that estrogen atrophy is going to affecting your urethra, and your urethra is going to start getting irritated, and or your bladder. So it's really, Kathy, the most important thing is just to have somebody look at your skin. All right. So I know you guys have, you know what? Oh no, I can't do that. So I've missed a whole bunch of comments on Facebook. I'm sorry, guys. But anyway, thank you, everybody, for your kind words. And hello, everybody. Hello, Emily. Hi, Aaron. Hi, Erica. Hi, Lisa. Hi, Brooke. Hi, Donna. Hi, Nicole. Aaron says Norwegian blood. Yeah, I tell you, we Norwegians rock. Emily says, Jill is the only person on earth who gets two things: the profound importance of the pelvic floor dysfunction, and that it alone can create pain that is so bad you'd think it has to be coming from somewhere else. Yeah, I know, right? Like, seriously. Amanda says, okay, so you guys, listen, for everybody on Facebook, understand that it will not let me scroll back. And so do not take it personally. If I missed your question, just answer it again, okay? Right now, I'm 20 minutes behind on Facebook with your questions, but I promise I will try to get through them all. All right, Amanda says, what if you get diagnosed with IC from chemotherapy or immunotherapy? How do they fix this? Bladder removal? Well, with chemotherapy, so with chemotherapy, you basically have a chemical injury. And normally what they would do before you even began the chemo, they would, there's a specific medication that they can give you that will break down the component in a specific type of chemo. Gosh, what is the name? I have a whole article on it on our website. Go over to icnetwork.org. There's a medication you can take with the chemo that renders the most irritating part of the chemo neutral, so it won't damage your bladder. Okay, so concept number one is especially if you're in chemo and it's already hurting, you ask the doctor, is there anything we can do that we can take to reduce the effect on my bladder? And there is a specific medication that does work. I just don't remember the name of it. They might also have you do a bladder coating that will give your bladder a little bit of extra coating and protection so that the chemicals of the chemo don't touch your bladder wall. So that's where something like a short-term Elmeron or a chondroitin-based supplement might be valuable. I mean, for the last 25 years, I've asked many doctors, what's the best thing an IC patient can do if they have to go through chemo? And the answer is, get a coating in there, get a nice protective coating in there, which would have been Elmeron. But of course, we now know that Elmeron is associated with retinal damage and eye damage. Or a chondroitin-based supplement, or even bladder installations. Oh, and you guys, by the way, I had to take my dad to the ophthalmologist on Friday, and I asked him, I said, are you treating pigmentary maculopathy from Elmeron? And they went, oh yeah, we all know about it. We all know to look for it. As soon as anybody says they've taken Elmeron, we immediately send them to the retinal specialist, which is fascinating. And therapeutically, you have to understand that the bladder is always healing. Once you're over the chemo, the superficial damage to the bladder wall should be better. You're going to have to follow the diet. You're going to have to protect your bladder wall. So no coffee, no green tea, no black tea, no soda, no cranberry juice, no lemonade. And that's probably going to be for a good 6 months to a year. I mean, you really have to protect your bladder and give it time to heal once the chemo is done. Bladder removal would only be done if the bladder was severely, severely damaged and shrunken. I mean, like the size of, normally your bladder is like the size of an orange. If it's shrunk down to the size of a walnut, that's when they might think about doing something like bladder removal. But that's rare, extremely rare. The radiation cystitis is more challenging because radiation can damage more nerves. And so for somebody with radiation cystitis, then they might have to be doing things that will calm nerves. And that's where, something like Peora, palmitoethanolamide, would be very, very interesting to try, or gabapentin or something like that. Erica went to Mexico, came back with a bad UTI. You're now on your third antibiotic because I also had 2 bacterial infections from eating contaminated food. Ew, that's what, honestly, that's why you're not going to see me traveling like to countries where there are more issues with food safety, especially right now, because everybody is under stress from COVID and Erica, you're not alone. I got a tapeworm in Hawaii. If it's going to happen to anybody, it's going to happen to me. I got a tapeworm, and then I got a sewage virus in my ears just from going to Hawaii. So don't take it personally. These are challenging. So the only thing I would suggest to you, Erica, is doing a next generation urine test, and let's make sure that they know exactly what they're treating. The advantage of the next generation urine test is that it will identify drug resistance genes, and it will absolutely tell you the correct antibiotic options to take. Kathy says, oh man, dang it, it's scrolled. I think you said you were getting rectal pain. Yeah, there's a very, very painful rectal spasm that's called proctalgia fugax. I've had it a couple of times where you just get this massive, massive painful spasm around your rectum. And that, again, is related to pelvic floor. And it usually goes away like within 5 minutes. But for those 5 minutes, you're just bent over. And Dr. Weiss talks about that in the book I recommend to everybody. If there's one book you need to have, every single person out there, it is this one, Breaking Through Chronic Pelvic Pain. Because this is a master class in pelvic anatomy, and it will help you understand how structures influence structures. he introduces a topic that no one else really talks about, and that is the concept of a mechanical injury. Here, hold on. Emily says, and I have a congenital defect if 40 times the normal number of nerves in the vaginal area, primary vulvodynia. Girl, Emily, holy moly. So you're not going to be, you can't use any soaps or any chemicals down there with so many nerves down there. Ryan says, speaking of the spine, I recently had an MRI and found out that I have a T9, T10 fracture. No surgery was suggested. Starting physical therapy in November, also getting shots for general back pain in the upper lumbar. The past 3 months, I have been feeling chronic fatigue. So depressing. I quit taking pain medicine, but miss it when I'm in a serious flare. Wish I could use medical marijuana, but can't because I still work. Can you use hemp? What about using a hemp cream, hun? You might be able to do that. If it's just a CBD cream without any THC in it at all, it shouldn't affect your ability to work. Trying to stay healthy enough to get 12 more years in and still be employed until I hit 60. I feel so guilty when I miss work. I'm taking 20 FMLA days this year. I see causes a cycle of stress, and dealing with my employer seems to even more stress. I see it's a battle. So it's not the IC that's the battle, the pelvic pain. It's, I mean, seriously, you got stuff going on. You have got a fractured spine. Any idea why that happened? It's really good that you're starting physical therapy. If your muscles are tight, we want to make sure that you're doing things that will help relax those muscles. And so maybe using a muscle relaxant at night or baclofen during the day, which is a non-sedating muscle relaxant, might help a little bit. And you quit taking pain medicine, but you miss it when you're in a serious flare. And that kind of points back to my initial discussion here. And that is the pain left untreated. There are consequences. The spine will adapt to the presence of pain. And so I don't, everybody has reasons why they do or don't do certain medicine. And I understand that. There's a lot of individuality out there. But if you're in intense pain and you have the opportunity to try to reduce that pain, it's reasonable. Jessica says she tried a muscle relaxer, ended up throwing up you tried a muscle relaxer and ended up on the floor throwing up in pain. Then you must have had a very severe reaction to the muscle relaxer. Do you remember what it was? You're probably sensitive to whatever medicine they gave you. Amanda says, evaluated in physical therapy and you don't have tight muscles. Well, if you don't have tight muscles, then maybe you don't need to work on that. Maybe your IC is coming from something else. Maybe you have a fibroid tumor pushing on your bladder, or maybe, maybe you've got a chemical injury of your bladder wall, or maybe you've got some estrogen atrophy going on. But if your muscles are healthy and they're not tight, then that's a really, really good sign. Then you don't need to be spending time there. Suzanne said, what I thought was estrogen atrophy turned out to be Hunter's lesions. I'm sorry to hear that. And I hope they treated them. That gave me some real change in, I think you meant challenge in downregulating the nerves, right? Deborah said, it's so horrible when my allergies are bothering me. When I'm sneezing and coughing, my bladder is so bad. Pain, and I'm waking up, urinating every half hour at night. Sometimes I think about pulling my bladder out myself with a knife, but I can't do that. I get so desperate. Hydroxyzine does not help. When I take an allergy OTC meds, that still doesn't help. What can I do? All right. So Deborah, clearly you have probably a mast cell activation syndrome. For anybody out there, if you notice that your IC gets worse during allergy season, you are not alone. That's well documented. And that has been talked about in some of the courses for doctors on IC. And so generally what they will do is they will have you use whatever antihistamine you will tolerate, and then also maybe Montelukast, Montelukast, Montelukast. I believe that was one of the options. Let me see if I can find the article I'm thinking of here. Hold on. Is it here? Here it is. So for those of you who don't know, the IC Network have a magazine called the IC Optimist that our members get. It's our pride and joy. It's an optimist because we are extremely optimistic about the future, and that just shows with the research that things are getting better. This is our latest issue. So every summer we outline the American Urology Association meeting. So I'm going back now to our 2018 meeting, our summer issue. And there was a fabulous class on IC that was taught by Robert Evans, Robert Moldwin, and Jennifer Fariello Moldwin. And because remember, we have to educate, they have to educate doctors in this, you know. So they went over this. So hold on a sec for the allergies. Let me see if I can find it. These are long articles. Where is it? I should just pull up the electric file, then I could just search it, all right? Conservative therapies. Where is it? Tricyclic. Ah, here it is. Oh, I was right. Okay, so it is montelukast. So antihistamine medications, hydroxyzine or cetirizine, inhibit mast cell release of histamines and can have a sedative effect. During allergy season, they suggested increasing the dosage and or using montelukast, especially in patients with a history of asthma. An H2 blocker, cimetidine, might also help patients with GI symptoms. So I was right with the montelukast. So Montelukast, montelukast. It is time to call your allergist. It is time to call your urologist and say that it is messing with your bladder severely. Okay. And let's see if they can give you either a stronger dose and or add some montelukast to that. And you guys, I always have to take a moment and say, now listen, I'm not a doctor. I can't give you medical advice. Anything I say here is not medical advice. I am just trying to educate you about what your options are. All right. So you take what I say over to the doctor and then you talk to your doctor about it. Or better yet, go on over to the IC Network and pull up the research study that talks about it, because I try to reference everything. Emily says, I'm much better now, but still can't wear pants and have to watch your diet. You must be referring to vulvodynia. Danielle says, my anxiety makes things so much harder. Yeah, guys, listen, anxiety, we got to nip the anxiety in the bud here. You know what? Okay, I don't want to talk about that until I watch the lecture again. I have to watch the lecture again before I talk what I was just going to mention. Cara, thank you so much for the 50 stars. That's very sweet. I really appreciate that. And I think somebody else gave stars too. And thank you. It just scrolled by too quickly. You guys are talking about oxalates, that foods that are high in oxalates can be more irritating. That is true. And foods that are high in oxalates can also cause calcium oxalate kidney stones. And so that's something that you can play with, especially if you're a little bit older and you've got some vulvar sensitivity, or for a guy, if you've got perineal sensitivity or rectal sensitivity. Try quitting spinach, berries, chocolate, and see if that makes a difference, because foods that are high in oxalates can be challenging. Jessica gives very, very, very smart words. She says, redirecting your mind from pain is great, but you still have to do the work, whatever the fundamental problem is. Jessica says, who determines that you have a pudendal nerve issue and how to treat it? I've had MRIs. Well, number one, it's based on your symptoms. If you've got sciatica, you have a nerve compression of your sciatic nerve. If you've got persistent genital arousal disorder, you have a pudendal nerve issue. They would normally do nerve blocks. And so it could be a gynecologist or it could be a pelvic pain specialist. Nan says, I've been using an estrogen patch for 18 years. What are your thoughts on that? Well, Nan, of course, systemic estrogen has been linked to cancer, breast cancer, uterine cancer, cervical cancer. I got uterine cancer from oral estrogen. This is the whole thing we walked through in these meetings 3 years ago, is all my testing, and ended up having to have a hysterectomy. And I have a whole video on it over on YouTube you can watch. So when you take a systemic estrogen, it is distributed throughout your body. It's very different from using a topical estrogen. If you're using a topical estrogen on your vulva or in your vagina, it stays in that tissue. It is considered much, much safer. So at some point in time, I think that you have to have a discussion with your doctor about the long-term implications of using an estrogen patch systemically. Now, listen, I love taking estrogen. I loved it. My skin felt good. My mind was alert. I wasn't losing words that I sometimes lose right now. I thought I was safe because I have no history of any breast cancer in my family or any estrogen-driven cancer in my family. My mother used it for 50 years. She's 91. She's alive and kicking. I thought I was really safe genetically from a genetic perspective about using an estrogen. And the reason why I started it is because I was having a lot of muscle cramping, which was a sign, a symptom of menopause for me. And so that was in my late 40s, early 50s, right? And it happened to me. Never thought it would. Leave it to me, man. I'm the special one in my family. If something's going to happen, it's going to happen to me. And so I don't want you to go through what I went through, hun. It was really awful. Scary as hell. And the surgery was really hard. I'm still recovering from the surgery 3 years later because I had pain at the side of my cervix. So woke me up in the middle of the night a week ago, actually. Really bad spasms right around the scar tissue. So anyway, so I talked to the doctor about topical estrogen, and maybe that would be more appropriate and safer. You just got to learn. Google it. Learn about the pros and cons of estrogen. Erica says, how many pre-leaf tablets can you take in a day? You only take it with food. And, like 1 or 2 before a meal. So maybe 6 at the most. You can't take pre-leaf like candy, guys. You cannot do that. That calcium has to go somewhere. It's going to end up in your bloodstream, and you could end up throwing kidney stones. We don't want you to do that. Hey, you know what? Speaking of that, I need to thank Pre-Leaf, our sponsor. Hold on a sec. So you guys, let's just talk about this for a moment. Pre-Leaf, the company that owns it right now, is DSC Healthcare Solutions, is the longest used supplement by the IC community. It does not act on your bladder. What it will do is reduce some of the acid load in your urine. So if you go to grandma's house and you don't want to offend her and not take a bite of her lasagna, knowing it's going to kill your bladder, what you might be able to do is take 1 or 2 Pre-Leaf before that meal, and that will help modulate the acid level in your urine so that you don't trigger a flare. So Pre-Leaf is an absolutely wonderful product. It's calcium glycerophosphate. There are a number of different ways you can alkalinize your urine. You can do a quarter teaspoon of baking soda in a glass of water. We don't recommend that because that's sodium and that could raise your blood pressure. You could take a Tums or you could use pre-leaf. But again, it's not candy. You don't eat it like candy. There are consequences to taking a lot of calcium. I meant to have that right there. So thank you, DSC Healthcare Solutions, and Pre-Leaf for your sponsorship and support for IC for the last 27 years. I mean, they've been around that long, and they're the most long-term consistent company who's supported IC outreach. We're very, very grateful for them. Emily says, I'm basically eating cardboard. If I cut out any more food, I'll be living off of water. That's not good. Emily, tell me about that. Jessica says, how many installations with Elmeron will cause eye issues? We don't have any data on that, Jessica. We have no clue. Normal medications tend to stay on the skin. The bladder wall it's a hydrophobic skin, which means it repels water. It's very hard to get medicine across the bladder wall. The way they do that is by alkalinizing it. And so when you have a rescue installation, what they do is they will do either Elmeron or heparin with some lidocaine or some marcaine and maybe some Solu-Cortef or whatever else the doctor wants to put in there. But the most important ingredient that is a little tiny bit of sodium bicarbonate. And it's that sodium bicarbonate, which changes the pH of it, that helps it pass through the bladder wall. But even so, it normally doesn't go very far. So topicals are considered more safer than oral meds. But that said, hun, we don't have any data at all on if bladder installations of Elmeron will reach the eye and cause eye issues. So I would err on the side of maybe not doing that, or maybe going to heparin instead. I mean, that would be me. You got to talk to your doctor about it. Emily, let's see. Emily is saying, but the crazy thing is, you find you can eat, let's say, the crazy thing is you might find you could eat more. For example, some of the more bland foods like potatoes are killers for IC vulvodynia because of oxalates. I don't know why more people don't know about that. I was like you, down to 95 pounds because of pain, and every food felt scary, but just have a look and try it. The first book on IC that was IC and diet that was ever written is called A Taste of the Good Life, a cookbook for IC, and it went into it's in depth. And this book, unfortunately, it's out of print, and she has retired and is not going to issue a second edition. We just found an extra one, and we had it in our store, and we sold it. So, this is my last copy right here. But any of you old timers should have that. You can read the whole section on it. Kathy says, I need vitamin C, ester C. Doctor said to try. Nope. I tried Little Critters Kids Gummy 4 days ago, only 60 milligrams. It flared. So, Kathy, yes, you're not alone. Lots of patients struggle with vitamin C because it is indeed ascorbic acid, and ascorbic acid and citric acid are the two acids which are going to irritate the bladder the most. You should give this a try. Maybe this would be tolerable. Where is it? Bladder Smart is a low acid multivitamin. So I had a company ask me 10, 12 years ago, the CEO of Farr Laboratories at the time, he said, Jill, if you could make anything for an IC patient, what would you make? I said, I know exactly what I'd make. I'd make a low acid vitamin. He goes, why? I said, because every day people call and say, is there a bladder friendly IC vitamin? And my answer was no. And so I would make a low acid vitamin. Well, 6 weeks later, he called me back and said, we've made your low acid vitamin. And it was called Multirite. And we sold it for many years, Multirite. The challenge with the Multirite pill is that it was huge because it was a multivitamin, multimineral. and it was hard to swallow. It was just a horse pill, and so I, just kind of had it. It was just too hard. I couldn't swallow it. I couldn't even swallow half of it myself. And so I had Natural Approach Nutrition, the company that makes Bladder Builder. I asked them if they would make us a low acid vitamin in a capsule. And they did. And here, let me go get it. So I'll show it to you. Hold on. All right. So this is the bottle I'm working on right now. So let's just open it up. First of all, it smells great. It smells herbal. So here it is. Look at that. And what they did is they put the daily dose in 3 capsules instead of one giant pill. So, and I love that because that means that you can titrate it. So like for me, I don't believe that taking more is better for pretty much anything because I'm so sensitive. And so I take one of these at night, 3 or 4 times a week. But you could go up to 3 if you feel like you needed more. And it's just so easy to swallow. It's not like, did I even have, where is the old one? I think I threw out my last multi-right bottle. The multi-right pill was twice as big and really thick. All right. Leslie says, coming off Elmeron now, tested last year, told the eyes okay, but noticed this year it's harder to read. Anything else I need to ask my eye doctor? If this damaged my eyes, I want to know, going for a checkup. Leslie, if you go on over to the IC Network website, on the front page now, there's a light blue box that says Elmeron Eye Information. You can just go over there, and that will give you all the update as well as the test you would have. Deborah says, please help me. My bladder is horrible. When my allergies are bothering me and I'm sneezing, I get 0 sleep. I'm up half an hour. So Deborah, we did. So if this is about potentially using a better antihistamine or maybe throwing in some Montelukast, that might help. I'm so sorry, hun. If you want to, I would be more than happy to talk with you offline. If you want to call the office this week, I would be more than happy to talk with you, and maybe we can come up with some more options for you that you can talk to your doctor about, hun. You're not alone. I mean, hopefully you're already working with an allergist and you've had allergy testing. Do you know what you're allergic to? Like for me, my allergies hit in my 20s and I was so sick for a couple of years, and they were adult onset them as a kid, but I have them as an adult. Allergic to Christmas trees. Like I was really sick at Christmas 3 years in a row. Oh my God, it was terrible. I'm allergic to the freaking Christmas tree. Got the Christmas tree out of the house. Guess what? It was much better. So it might even be something in your house that you're reacting to. Kelly says, I have severe vulvodynia. I've tried many different medicines. Any suggestions? Kelly, yes. Did you know that vulvodynia is often caused by tight pelvic floor muscles? Tight pelvic floor muscles. The tight pelvic floor muscles are squeezing the nerves that are supporting your vulva. Think about the consequences of a tight muscle. Like your muscles are supposed to be long and lean, right? They're long and lean. When they're tight, unfortunately, the blood vessels and nerves that go through that muscle are now restricted. And so therapeutically, what we want to try to do is slowly work these muscles back down into their long and lean approach. Another tidbit for you guys, for men and women, like what the hell is up with the perineum and why is it so painful? The perineum is that little bit of skin that goes between the rectum and the vagina, or for a guy, the rectum and the scrotum. And it's like the little piece of nerve, this little piece of skin that's like an inch and a half, maybe an inch long, maybe 2 inches long. It can be like fire. Like with my vulvodynia, what I thought was vulvodynia back then, it was my perineum that was screaming in pain. Yeah, we're talking ice packs. Well, guess what? Guess what's immediately above the perineum? It's called the perineal body. It is an attachment point for 4 muscles. 4 muscles. And so if those muscles are messed up immediately above the perineum, then the perineum is going to start screaming. So we want to look at what's going on with your muscles. If you've got perineal pain or vulvar pain or scrotal pain or testicular pain or urethral pain, if sex is hurt, if sex is painful, if you dread going to the gynecologist because you know that speculum is going to hurt, you have vaginismus. You have tight muscles, and you probably have tight muscles for decades. Why? That's what we have to figure out. Why? For some of you, it might be because you got one leg longer than the other. You might not be walking correctly and putting strain on your pelvic floor, or you might have a hip issue. There might be, again, a mechanical dysfunction. Hi, Marion. Thank you, Carol. Carol says, it's good to see you. Glad you're safe. Yeah. Erica says, my urologist suggested that I start cimetidine. Yeah, give it a shot. Just, you got to read the pros and cons. Lauren says, hi, Jill. My mom ordered me a bottle of Desert Harvest aloe vera because she heard you talking about them and a coworker raving about them. She sent them to me. I've been taking 4 to 6 per day, and wow, I've never been impressed. Never been so impressed. It's helped me to urinate easier, and I actually feel relief, and it has made it easier to urinate going from an hour or longer to pee. I still have other issues and my anxiety and other issues, but the actual urination part has helped tremendously. Yeah, aloe can be very comforting and soothing, especially to the urethra. And so if it's always worth trying it. The challenge that we have with aloe is that some patients are quite intolerant to it, and they can have bowel issues. The new aloe product that we have that I really am excited about is this one, Aloe Path. And Aloe Path is the same, it's an organic anthraquinone-free aloe, but they've also added palmitoethanolamide for pain relief. And so this is kind of taking aloe in another step forward in terms of providing potential more comfort, a little bit more pain relief. And so this would be something viable to try also, especially if you struggle with pain. Nan says, can getting cocktail treatments hurt your bladder if your IC problem is only your pelvic floor issue? Well, okay. So let's think about this for a moment. We know that there are 2 reflexes in the pelvic floor. In the pelvis. We know that there is the viscerosomatic reflex, which basically says, can an organ change muscle behavior? And the answer is yes, that if your bladder is in pain, your muscles are going to get tight. We know that. That's a given. If a man takes a blow to his tender bits, and you could see that his testicles are being pulled closer to his body to protect them. And that is, in fact, a perfect example of a guarding reflex. So whenever we have bladder pain or anything like that, our pelvic floor is going to get tight. And our therapeutic priority for that patient is to calm and soothe the bladder, hoping that the muscles will, and usually the muscles will release after a trauma like that. But the more important reflex is the somatovisceral reflex, and that is, can muscles change organ behavior? And the answer is Yes, absolutely. Muscles can change organ behavior because if you've got tight muscles, it's restricting blood flow to the organ. It's very hard for the bladder to be healthy if it's only getting half of the blood flow it would normally receive. But it's also, tight muscles are also damaging nerves and compromising nerves. And the more damaged the nerves are, those nerves start to release toxic substances in the bladder wall that then causes the bladder wall to break down. So, our therapeutic priority for this group of patients is not to go to the bladder, it is to first go to the blood flow. We want to restore blood flow. Our therapeutic priority is to restore blood flow. We know that once we do that, the bladder will receive the blood flow it needs to try to heal itself and be more healthy. So, getting to your question, can cocktail treatments hurt your bladder if your IC problem is your pelvic floor? Well, ultimately, your number one goal should be to be working on that pelvic floor. But if you're suffering with secondary bladder discomfort because of that, then doing something that will calm and soothe and protect your bladder makes sense. So doing something like a rescue installation that could, calm down the nerves and give your bladder a little bit of relief while you're working on the muscles, it should be okay. But patients have different tolerances to some of the chemicals. And so it depends upon, you might be okay with lidocaine or you might have a reaction to lidocaine, but you might need Marcaine instead. There might be another option for you there. Erica says, I've been trying different medications to redirect my focus to another place other than my pain and discomfort, especially at night when I lay down in bed. This flare I'm in is terrible. I'm trying everything I can. Erica, I hope you guys, okay, anybody in a flare, I'm going to be starting our Zoom meeting in just like 5 minutes. Come into the Zoom meeting and let's go over it. You get a coaching from me. It'll be a public coaching. People will hear on YouTube and Facebook, but Nancy, thank you, Susan. Taylor says, do I have a link between adrenal dysfunction and pelvic pain? Actually, I'm just learning about that right now because I have another patient who has an adrenal issue, and I will try to do an article on that, but I can't talk about it. I don't know enough right now. Julie says, your hair is so thick. I'm the crazy hair grower. It's ridiculous. My hair grows so fast. I might show up with hair like here, and you watch, a year later it'll be down here. It grows so fast. Knock on wood. I don't want to jinx myself because I love my hair. Hi, Ruth. She wants to know the exact link to buy products from our website. Just go to icnetwork.org and click on the store. It's upper right-hand corner. icnetwork.org. All right. Facebook. I am so sorry, my friends on Facebook. I have been looking at YouTube. Let's just take a look over at Facebook. We are simulcasting. Hello, my friends on YouTube. How are you? Mickey says, I've been depressed because of the relationship I've been in for 8 years, has said, because of the pain I have with sex, he feels we should just be friends. Oh, honey, I'm so sorry. So now we've got to think about, why is sex painful? 2 logical reasons. Number one reason is going to be vaginismus, that you might have very, very, very tight muscles, or number 2, dryness. Those would be the 2 things. So, Mickey, what is going on with your pelvic floor? Do you know? Have you had a pelvic floor evaluation? Mickey said she sent $25 for the magazine a couple months ago, and you haven't received it yet. Mickey, you know what, hun? I will try to figure that out. Hold on a sec. Let me make a note. So we were evacuated about 6 weeks ago, right? So, the fires in California are terrible. So hold on. Mickey, if you could email me icnetwork@mac.com, your contact information, that would be great. And I will check that for you. Absolutely, 100%. Donna says she has allergies and uses Claritin D and that helps with the itching. Awesome. Nicole said, did I say that if you take too much pre-leaf, it can contribute to kidney stones? Yeah, absolutely. It's calcium. If you're prone to calcium-based kidney stones, they normally say you should not be taking any calcium products. Mickey says tightness, and yes, therapy many times. Okay, thank you. So Mickey, all right. So Mickey, so what they've told you is that your pelvic floor is very tight many, many times. Have they been able to explain why it's tight? Do you have a bad hip? Do you have a bad knee? Do you have a bad foot? You have scoliosis? Do you have an SI dysfunction? I mean, girl, seriously, this is the book for you. You got to get this book. No excuses. It's free on Kindle Unlimited. You don't even have to pay for it. If you have Kindle and you use Unlimited, but it's $9.99 on regular Kindle. Okay, so did you reach? So she says she bought it. So why do you think your muscles are tight? Do you have any clue at all? Did you read the chapter on the feet? Did it just blow your socks off like it did me? Okay, and while we're doing that, I'm going to start the Zoom meeting. All righty then. All right. All righty. So we're now going to enter the portion of the meeting where we are going to do Zoom. And you can come in and tell your story and get a coaching from me. Now, for people in Zoom, understand that everybody's going to hear this. The Facebook group and the YouTube links are still open. And so if this is too personal and you don't want to talk it, don't come into Zoom. You're welcome to call me later this week. All right. But this is a learning opportunity for everybody. So getting back to Mickey, why are her muscles so tight? She said she fractured her pelvis in 2 places running, and you've also had surgery on both feet. There you go. There you go, girl. So the question now is, are you walking normally now that you've had your surgery on both feet? I mean, I would love to hear what you think of his chapter on on the feet. Becky says hormone creams helped a lot with intimacy. Also, that's true because if you're dry, using some estrogen will help your body produce mucus. All right, I am putting the Zoom links in. You will be admitted one at a time to Zoom. And again, Facebook, I apologize here that it's not going to let me scroll back. Karen said she had excellent results with Elmeron. Does not seem to be helping much. Karen, well, most people are not taking Elmeron anymore because it causes retinal damage and in some cases blindness. And so it's not something people are really walking to anymore. They're moving instead to chondroitin-based supplements. Erica says, is there something special about the aloe? No, it's just they've been around for a long time. They've been around for a good 20, and that's why they have such good name recognition. pregnancy with IC advice, JD, I've got a pregnancy resource center right on their website on the IC network. Go to icnetwork.org. Patients have babies all the time. You're going to be a great mom, but you have to understand that some patients flare and other patients, their symptoms go away. All right, Facebook, I'm going to give you your Zoom link. Oops. Carol says, I have IBS and IC. I'm working with a nutritionist to help with both. Found out I'm lactose intolerant and gluten sensitive, so I avoid dairy and gluten. And she put me on a probiotic that seems to be helping. Good, you figured that out. All right. Okay, guys. Hey, listen, let's just take a 1-minute break. The great thing about doing Zoom meetings is y'all can go to the bathroom whenever you need to, and I'm going to go to the restroom, and then we will come back and work with some patients over Zoom. All right, I'll be right back. All right, I'll be right back.
It doesn't go.
Somebody's got their mic on. Who would that be?
Hi.
Hi there. I have you turned off, hon. All right. So I will turn you back on in a minute. I just want to make sure. All right. So for anybody who wants to talk about their symptoms, anybody who wants to get some personal feedback, this is the time. If y'all want to do it, that's fine. If you don't want to do it, that's fine with me too. I can go either way. I am flexible. Let me know if you have any problems with the link. Jennifer says, I took a microgen and pathognostics test, which showed high levels of E. coli and E. facialis, but my urine test is negative. What are your thoughts? Hun, that doesn't mean that you have an embedded infection. It just means that the urine test they gave you was not capable of growing out those bacteria. And so there was a very big lecture given at the American Urology Association this summer that very specifically said that next generation testing will be replacing urine cultures in the very near future because they are so much more accurate. And so I would be relying on the next gen testing. Emily says the hardest time was there wasn't Facebook and you had no support, no one to talk to. Emily, the IC network has been online for 25 years. We have a massive support forum, and we did live support group meetings on our website for years and years and years. I'm sorry you didn't know about us back then. Julie says, I've asked my gynecologist if I might have IC, and she says probably not because I've been battling another UTI this week and taking Cipro. Why are you taking Cipro? Cipro is not recommended for UTI, uncomplicated UTIs anymore. Cipro is actually linked to some very, very severe adverse events. The FDA has issued 6 or 7 very urgent safety warnings about Cipro use, Julie. You got to be really careful about that. So if you're struggling with getting recurring infections because of estrogen atrophy, then you would want to use something like Allura or Prevent. Those are your best guesses. Where is it? Prevent. And so this, there's definitely a group of women who get recurring infections, and we have to, and normally they're older, they're menopausal, and we know why, because research has found the bacteria living quite happily in the vagina about 24 hours before it arrives in the bladder. So that made the researchers go, well, what's happened to the health of the bladder of the vagina? Why has that become a safe haven? And it's estrogen atrophy. So normally they would be giving you an estrogen product to use vaginally to improve the strength and the ability of your vagina to defend itself against infection. And so they would be giving you that. And so that, you've got the Vagifem, but then it would be something like Allura or Prevent. And so this might be really interesting for you to try to see if that helps you, hon. Okay. All right, let's go over to Zoom. Oh, we only have a couple people today. That's okay. Not a problem. Let's see. Becky, are you there? Hello, Becky. How are you today? How is life? Okay, hold on. Julianne, I will come back. Hon, you had walked away, so I thought you had walked away. So I went to Becky first. But just hang tight, Julianne. We'll be good. Okay, Becky, I'm trying to unmute you. Can you unmute yourself? There you go.
Okay.
How are you?
Hi. I'm okay. I can't complain. Safe, healthy, right? How are you?
Hey, you know what? Same here. I have a house. It didn't burn down, so things are looking good.
That's true. Yeah, I'm glad to see you because I haven't been on in a few weeks. And then, there were times when you weren't able to be on because of the fires, which is scary.
Yeah, well, all the hills are black. The big fire, the last fire burned 3 houses away. And so everything out my window is now black. All the trees, everything. It's just, but the good news is we're not going to burn again. So that's good. But
that's good. I'm so glad that you're safe.
Thank you. Well, how are you? How is your IC and how's your pelvic pain?
So I'm doing okay. I was having a flare maybe like a week and a half ago for about a week. And then after that, I started experiencing vaginal itching and irritation.
Okay.
And, I used to have chronic yeast infections years ago, but, I did boric acid for a period of time under the doctor's care. And I haven't had them in a while. And then I thought I had what I thought was a yeast infection and turned out to be the estrogen atrophy. So I've been, that's been treated, and I'm using the estrogen cream, and I also have a testosterone cream. And all of a sudden I'm having the same kind of itching, burning, dryness. And I don't know what it is. So I went to a doctor, not my usual doctor, but I went to a gynecologist, and, I got a swab test, but I don't have the results yet. So I'm waiting on those results. She prescribed me a cream that has some kind of antifungal.
Okay.
And cortisone, but I'm afraid to use it because I kind of think that might not be the problem. So I want to wait and see what.
What do you think the problem is? What does your gut tell you?
I have no idea. It was I had IC for several years, and then I started having the estrogen atrophy, and I thought, okay, here I go. I have to adjust to this new normal now, because for a long time, you know, the doctor I'd been seeing said, oh, you know, that dryness, that's like within the range of normal for your age. And it wasn't until I went to see a new doctor that she looked at me and said, oh, you have atrophy, like, let me treat it. So yeah, who knows?
Well,
You know,
okay, but so let me make sure I am understanding what you said. So you had a flare, and
like a black.
and it was a bladder wall. Was it a bladder wall flare or was it a UTI?
It wasn't an infection. It was just a plain old, you know, stress, hormones,
Okay.
you know, type of flare. Yeah.
And then after the flare ended, you ended up with vaginal symptoms or vulvar symptoms that
That's right.
are suggestive of a fungus, yeast. Your doctor is saying yeast. And is that irritation inside your vagina or out on your vulva? Is it internal or external? Just out of curiosity.
It's both, but I feel like it mostly feels external. The doctor said that she didn't see any yeast, but you know, just prescribed me that anyways. But I'm like, I don't know if I want to use it yet.
Well, I will tell you that I personally have had very, very good success with nystatin triamcinolone cream. I went through a period of time where I had a chronic Candida glabrata infection, and it was from taking antibiotics. It was an old IC protocol where I took antibiotics for 3 or 4 months, and I ended up with this wicked infection.
I've been there. I took antibiotics for a year at one point.
Right. Did you do the Fugazzotto protocol?
I don't know. I mean, the doctor didn't.
Okay. Yeah. So right. And so how long ago was that?
Oh, that was probably about 7 years ago, maybe.
Okay. Okay. Well, you know, the nystatin triamcinolone was what got me through the worst of that, because what I did not understand is that my yeast was concentrated on my vulva as compared to in my vagina, because they did, when you've got a drug-resistant candida infection, they tend to throw a lot of diflucan at you.
I'm allergic to that. So
yeah.
I developed an allergy to it. I took it as a teen, you know, when it was new, and then
right.
Yeah, I haven't.
Right. What I didn't understand is that an oral antifungal does not kill yeast on the skin particularly well. And that's where mine was. Mine was really burrowed into my skin externally. And so it was the nystatin cream, and specifically the nystatin steroid cream, that was the most helpful for me personally. So,
interesting.
You know, but you know, we don't know. I mean, you could potentially have a next generation vaginal swab and see if you have a fungus. That's one thing you could do. But I would also, but you just had a flare. And so we know we have the viscerosomatic reflex that when you're in pain, your muscles will get tight. So is it possible that your muscles are super tight down there, and that might be triggering some of this pain and discomfort? What do you think?
I mean, who knows? I have problems with the, you know, pelvic floor, the high tone pelvic floor dysfunction.
Mm-hmm.
I just finished a round of physical therapy. You know, they discharged me. I hate that. I wish they would just keep me and I could just go, you know, once a month or something, but the insurance isn't like that. So yeah, I mean, do you think that, I guess it could be a symptom of the tight muscles? I would be surprised. It, you know, yeah, who knows what's causing it, and that's frustrating.
Yeah, but remember when you're under intense stress, you will subconsciously tighten your pelvic floor as part of as part of the fight or flight reflex. So by your own admission, you went through a wicked period of stress and you had a fairly wicked flare. So your muscles are undoubtedly responding to that in some way. So when you go to pee, can you start your urine stream right away? Or are you hesitating 5, 10, 15, 20 seconds before you can relax enough to empty your urine?
Yeah, I've been having trouble with that.
Well, if it walks like a duck and talks like a duck, it's a duck. You're having symptoms of tight muscles, hon. So
I should get out the and go back to physical therapy.
I think you should. Do you have a wand?
I do. Yeah.
Why don't you get the wand out, and you've used it before? Check your muscles, see where they are.
Yeah.
That would be my guess. I wouldn't be afraid of I'm not afraid of the Niciceptors steroid cream, and I can understand why your doctor would say, let's try that, because it's always a possibility.
Okay.
But that's probably the lesser of two. I think you can figure this out literally in the next 5 minutes just by using your wand and seeing where you are.
I might try that. Well, thank you for, not telling me that it's okay to use the cream. Maybe I'll go ahead and pick that up, tomorrow too. Might as well try both things.
Well, talk to the pharmacist, see if there are any issues with it. Was it a Niciceptor cream?
I don't know what I've definitely used Niciceptor before, but I don't know what the antifungal is in this particular cream.
Well, the Niciceptor is the antifungal.
Yeah,
and
because it has cortisone and then some sort of antifungal, but I don't know. I don't remember which.
Okay. Well,
yeah.
You got two logical things. You can rule something out very easily in the next few minutes, and when in doubt, talk to your doctor and say, hey, is there a chance that my pelvic floor is locked down again? And maybe what they can do is give you that referral back to physical therapy. Wouldn't that be awesome? Right?
Yeah, that would be nice. I feel like physical therapy is so helpful to me. I'm really grateful for the therapist, and they make me feel really comfortable too.
They do. Yeah.
It's not scary like going to the doctor.
Isn't that funny? Isn't it funny that, that so many women are afraid to kind of take that, and men too, taking that step of having somebody work down there internally. But once you've done it and you see how good it is, it's like, oh, piece of cake. Piece of cake.
I like therapists, and they've all been really nice and friendly and welcoming and made me feel really safe and comfortable.
Yeah.
So.
Well, listen, I think if it persists, it's been how many days has this been happening now for?
Been probably a good week and a half almost.
So, I think you could call your doctor, see if you can get a same day appointment and see if they'd be willing to do a swab. They normally just do a microscopic check for yeast. So they just
I had a swab test on Tuesday.
Oh, that's right. You just don't have the result.
Yeah. So
yeah, but
we'll see.
They normally just take it out, look at it at the microscope, come back into the room.
No, I don't know. I guess they were sending it out, maybe.
Oh, that's disappointing. Because yeast is really easy to identify under the microscope.
Huh.
Weird.
Well, maybe when she said I don't see any yeast, maybe she meant she didn't see any in the swab. I thought she meant she didn't see any signs of yeast on the skin or whatever.
All right. Well, Morgan, I'm sorry, but that's my guess. All right. Good luck.
Thank you. Thank you so much. And thank you for being here for us. I'm really, really grateful for all that you do for us. You are very, very welcome. And I want to hear how you're doing. I bet that a week from now, you're going to be feeling pretty good. And I wish that for you. And I hope that happens for you. I hope so. Thank you.
Okay.
Thank you.
Okay. All right. Julie Ann. One last thing, Becky? Did you have one last thing to say?
Oh, no. I'm just waiting.
Okay. All right, Julianne. Oh, wait. You unmuted. You unmuted, and I unmuted. Okay, there we go. Hey, girl, how are you today? You look beautiful.
I'm doing a lot better.
Yay! I love it when you're doing better.
I was diagnosed with pelvic floor dysfunction.
There you go. And what do you think of that? What has your mind been blown?
Yes, it has.
Yeah.
because it makes a lot of sense now that I look into the symptoms and I look at them and I'm like, oh, yeah, that makes a lot of sense.
And haven't you had children? Have you had children?
No.
Okay. Can you remember any falls, car accidents, anything at all like that? Any traumas?
I was always taking stumbles down the stairs growing up.
Oh, there you go. Yeah, there you go. We have one very, very memorable case of a guy that I was working with in the last year or two who was sliding on a wooden floor, and his feet slid out underneath him, and he landed on his butt right on the top of the hardwood stairs. And then he went butt first down an entire flight of stairs. And within a day had all the symptoms of IC, and of course it was pelvic injury. So what are their plans for you then? What are you going to be doing?
They prescribed diazepam.
Diazepam, okay, which is Valium.
Yeah.
Is that orally or is that as an insert?
It is as an insert.
Good. That's very, very good. Have you tried it yet?
No, I got it in the mail yesterday.
Okay. So
it was $50 for 20 of them.
Well, you can shop around at different compounding pharmacies and see, you might not need more. It's going to be, and remember that a pill is a short-term solution. A medication is a short-term solution, whether it's a suppository or an oral med. What we got to do is get in there and start working with the muscles. So do you have an appointment with a physical therapist yet?
I was referred to one, but it's $160 per visit.
Well, if you can go at least once, that's the most important thing to do, because we've got to try to understand the anatomy of your pelvis. It's very important that somebody study your muscles. And if there's any way that you can swing that, I would try to do that, because we need to know. Otherwise, you're guessing and you're just masking the symptom with the med, where we want to try to fix the problem. And you know what? It's gone. Your screen has frozen. Are you still there, Julianne? Can you hear me? We may have lost her. Are you there? Uh-oh. Internet malfunction. All right, she has disconnected. And so let's give her a minute and see if she comes back in. Time for a water break. Kathy says, what's the phone number for the IC network? It's 1-800-928-7496. It's on our Facebook page. It is on the top of our website. You can't miss it. 1-800-928-7496. All right. Well, we lost her, so I'm going to go on to Stacy. Hello, my friend. How are you today?
I'm doing okay.
Awesome.
I do have questions for you, though.
All right. Hit me.
I was on Facebook and I heard you mentioning allergies, and that's just a topic for this time of year. And so this past year, when all this craziness started happening, my allergies just happened to get really bad. But I was always on the hydroxyzine for years, and that always kept me okay. But I allowed my daughter to bring a pet around, and I started having real angioedema and really bad allergies. So, long story short, I found that I'm allergic to pets. I'm allergic to plants and environmental stuff. I had to go off my antihistamines for 5 days because I felt like I was having sensitivities to food as well. Turns out I'm not allergic to foods, but she did say I probably have intolerances, which makes sense because we have the IC diet. how exactly does the allergies impact IC? When you have to keep in mind the fact that out of the 5 subtypes, I have 4 of them. I fall in 4 of those categories.
Okay. Do you have Hunter's lesions?
No, that's
Okay,
the one that I do.
Well, thank God for that. Thank God for that. So if we look at the anatomy of the bladder, so this is a 3-dimensional view of the bladder wall. And obviously it's not blue. That's just for graphic purposes. So there is an outer coating that we call the urothelium, or the gag layer, urothelium. And the purpose of this is to keep whatever's in your urine from not reaching the more vulnerable cells beneath. So underneath the mucosal barrier, we have the urothelium. And this is like 4 layers of the largest single cells in the human body. These are monster cells. It takes a minimum of 2 weeks for one of these to be replaced when they're damaged. Underneath that, what do we have? We've got nerves in green. We've got blood vessels. And what you can't see in here are mast cells. There are mast cells immediately in this layer too. And so you know that when you are bitten by a mosquito, that the mosquito injects venom in your skin, and then the mast cells immediately release histamine. And that's part of the way the body defends itself. And Julianne just came back in. Julianne, I'll be coming back to you, Julianne, okay? All right. So what causes the swelling and the itching and the pain and the irritation is actually the mast cell releasing histamine. We describe IC in some patients as like 100 mosquito bites at once in your bladder wall. Because wherever you're missing mucus, urine is getting down in here and starting to do damage, including causing mast cells to release histamine. And that is why using an antihistamine is an important part of the treatment plan for patients with bladder wall issues.
So how is this mast cell diagnosed? Because wouldn't it show up during this allergy testing?
No, so some people can have an overgrowth of mast cells called mastocytosis. Is that right? Mastocytosis?
Yes.
Okay. And so if you happen to be somebody who happens to have a lot more mast cells in there that are being triggered, then that is kind of its own separate disease process, because they find mast cells throughout the entire body, not just in the bladder. And so using more aggressive antihistamine therapy would be normal in that circumstance. Do you know do you understand the difference between an allergy and a sensitivity?
Yes, as well as an intolerance.
Okay. And so have you had food sensitivity testing?
I did not do the testing because my allergist believes that it's not reliable. She said, basically, I am a registered nurse. So she said, basically, with your knowledge, if the food is causing these reactions, don't eat them.
Okay. So like I don't think I have any real food allergies. What I have are sensitivities. So if I eat chocolate, I get bowel spasms. If I eat oatmeal, I get bowel spasms. I mean, and I don't mean little ones. I mean, holy hell, mother of God, I am bent over on the toilet until wherever it is out of my body. So can you describe the reactions you're having? I mean, is it systemic or is it just your bladder?
It's systemic.
Okay.
I swell. My face swells. I break out with the acne, and my stomach swells, sometimes to the point where I can't drink or anything can get down. My bladder burns and swells. and I have the frequency and stuff like that, and it continues on. I get the swelling even in my legs and whatnot.
Wow. Okay.
Mm-hmm.
And so what are your top foods that bother you?
I definitely have to stay away from dairy.
Okay.
I have to be careful with breads. I have to be careful. Chocolate is one of them. Sugar is a big one. And some vegetables, but obviously the acidic ones. It doesn't only affect my bladder, it also affects the mucosa in my mouth.
Really?
Yes.
Interesting.
Yes. So
okay. So I agree, at least for me, I do better without gluten. If I start eating too much gluten, it's a problem. The swelling is real.
Mm-hmm.
And I also agree about the dairy. I haven't eaten dairy consistently, except for maybe a little bit of ice cream every now and then, in 30 years. Because I found that dairy caused a lot of cramping, kind of superficial cramping in the bowel, just made bowel movements more painful and kind of mucousy and icky. And things like flour tortillas. I don't do that. I can do corn just fine. Can you do corn?
Yes, I can do corn.
Yeah,
Mm-hmm.
yeah. So how is this messing with your diet then? With your IC diet? How are you eating well? How are you doing?
I'm just really, I would say that no, my appetite is pretty poor right now.
Oh.
I'm losing weight, which wasn't the worst thing because I was really obese, but I just don't feel well a lot of days, and so.
Do you have, okay, so let me ask you a question. When I was starting in my 20s, when all the food stuff started, and all the way really for about 6, 7, 8 years, including after my IC started, I had what I called sick all over days, where I just felt so ill. But if you asked me why, I wouldn't have an answer for you. I just felt terrible. And they would, right? And they would come and go, but it would be like 4 sick days and 3 good days where I just remember crying to my mother saying, I don't know why I feel so bad, but I feel so bad. And do you have that too?
I have, but I really have found it to be in correlation with my diet. I honestly have to say that.
Okay.
That to be when I eat. I actually went vegan for 1 year. And that was the best I felt. But because I'm such a picky eater, it just wasn't giving me everything I needed. So.
Right. And I did that. I did that too. I do way better when I go more vegetarian. What turned the sick off over days for me was Visceral hydroxyzine. Like literally within a week of me starting the Visceral, they were gone. And it was stunning.
It's funny you mentioned that because I used to be on hydroxyzine, but I was just switched because of the severity of the angioedema. I was switched to Zizol, and I take that twice a day, and I'm doing better than I did with the hydroxyzine. With that.
Oh, good. Okay, that's good.
And I am doing better. I was just curious of the mechanism of if it's not a true allergy, how is it still affecting my IC? And that's what I was curious.
Well, because if your bladder wall is compromised, you have mast cells. They're going to trigger histamine anywhere you have injury. Okay. So that's just happening. So what's the condition of your bladder wall?
See, that's the whole thing. I wasn't having any flares. I was in control. I mean, you have educated me enough, and you have sent me to enough resources where I managed pretty well. And so it was simply from going off of the antihistamine for 5 days, and now I'm not in the worst flare that I want, but I have the discomfort, I have the burning, I have the frequency back again, and I'm trying to get back into control again.
Is it better now than it was 5 days ago? Are you improving?
It's not where it needs to be. So I know I don't feel good today.
What's the dominant symptom of the flare?
The dominant is the burning.
Okay.
The dominant burning. I also have which I was going to actually bring up next. I also had an inner stem, and it malfunctioned. And to come to find out, I have 4 nerves that are very severely damaged in both legs. So I go totally numb in varying degrees from my lower back all the way to my toes.
Oh,
So,
and was that from the inner stem?
That was from the inner stem. But before the inner stem went in, me and you talked before, I have a pelvic deformity from being in a very serious motor vehicle accident. I'm one of those people who my pelvis rotates forward and one leg becomes shorter than the other. I told you before that my doctor said it was the worst case he had ever seen. And so now I have numbness, so I can't determine if I'm walking properly, and I can't feel to determine whether or not it's out of place. And then all of a sudden I wind up in severe pain, to only find out that I need to have manipulation, I need to do the Valium, and I'm now in a flare. Well, and I don't know how to manage,
Yeah, you got to break it down into manageable sections, hon. I mean, you just do. Number one, I'm so sorry that you were damaged by the inner stem. You're not alone. Hopefully you filed with the FDA, the MOD database. You filed a patient report to share what happened to you. Have you done that yet?
No, I didn't even know about it.
Yeah. It's our adverse event reporting structure. So remember the old TV show MAUDE, MAUDE? So if you Google FDA MOD database, make sure you go in there, and file a full report of what happened to you. It's very important that get filed so we can monitor that. Okay. So let us ponder burning for a moment. Let's just ponder the symptom of burning. So where is the burning? Where is the location of the burning?
That's hard to say. I feel like I don't know if it's coming from my vagina, and I don't know if I feel it at the bottom. I wouldn't say it's at the bottom.
Is it internal or external, the burning?
It's internal.
Is it in your urethra or your vagina?
Maybe my vagina, but it could also be with the sensory problems. It's hard to say. With the sensory problems, it's hard to say.
Okay.
But it's internal, and it doesn't feel like a belly ache or abdominal ache, like it's right on the outside. It feels like it's deeper inside.
When you go to pee, can you start your stream right away, or do you hesitate?
I can start it straight away, but I did have to use a Valium suppository yesterday. I did have to use one, so I'm feeling better. I have relief from that. Did
that relieve some of the burning?
No, the burning is still there.
What is the health of your skin? Are you getting dry?
No, I never had a problem with dryness.
How old are you?
I'm 41.
Okay. Are your periods normal?
I've been in medically induced menopause since I was in my 30s.
Okay, so you're menopausal.
Yeah.
Okay, you are.
I don't have dryness.
Okay.
Really
okay. So whether you feel it or not, your body and your tissues are responding to the loss of estrogen. Okay. And so you are in estrogen atrophy. If you are medically induced, you are in estrogen atrophy. And so again, when we look at this, you watch, this is going to be this piece is probably going to be evidence in one of the Elmron lawsuits. But anyway, it's still useful. So you're at the point now where your mucosal layer is thinner. And things are starting to get through and irritate you a little bit more. So it's possible you just hit that point, kind of not of no return, but you hit that pain threshold where your estrogen levels got to the point where just finally it's starting to trigger pain.
Okay.
And so you can't ignore that. You've been there for a decade. You're dry. You might not feel it, but you're dry. And so the quality and health of your skin for every woman out there is a separate and distinct issue from the IC, but something you've got to pay attention to. And so I would, at number one, I would absolutely want somebody to look at your skin and let's see if it's showing dryness, because that skin level burning can be that. Like, and remember, the urethra is kind of the canary in the coal mine when it comes to estrogen atrophy. So it's a urethra that will often start screaming first, and it can be kind of a burning sensation. So, although for me, it felt like there was something stuck in my urethra that would not come out, like a drop of urine stuck in my urethra that would not come out. Do you feel anything like that? Do you feel like there's a foreign object in your vagina or in your urethra?
I know what you're talking about because I've had that in the past. So I know
Okay.
exactly what you're talking about. This is more like in the range of what can be mild to severe for me. This is more closer to mild. You know, it's just
Okay.
it's just that it's going in the opposite direction from where I've been, and I don't want to go there. You know what I mean?
Yeah. Well, with any luck, the histamine will kick in and will stop, you know, I mean, the antihistamine you're taking will kick in and stop that kind of process from happening.
Okay. Now, is there any tests though, like bladder wise, like, is there anything we can get to diagnose as whether it is like mast cells or not?
Well, they can do a biopsy, but I mean, but you're not having bladder symptoms. You said your symptoms are low. They could do
No.
they could do a vulvar biopsy.
Yeah, I'm just more curious of causes. I'm more curious of more factual. I just would like more factual information as to, you know, what is causing this, why are the foods affecting me like that?
Well, okay, but do you have pain as your bladder fills with urine that is relieved by urination?
When I'm in a flare.
So are you having that this week then?
Yes, I was. I was having the frequency. I was having all that. I am back on the antihistamines. I've been on them for at least 3 or 4 days, so that has calmed down.
Okay, so that's improved.
Mhm.
I mean, I understand you wanting to have like the perfect test that will tell you exactly what's wrong, but
Yeah.
your case is it's extremely complex, and you now have nerve damage. You know, and so I don't know. I mean, I would talk to your doctor about if that's viable. My concern would be that if you do something more aggressive, you're just going to irritate the nerves even more. And do we
You're
want to
right.
do that? You know,
You're right. Mhm.
I,
But
I
a lot of times, you know, the saying is, in order to truly treat something, you have to know what it is.
I know,
And
but do you think that this is okay? So let's just get real here. Let's get just totally real here. Do you think like you have cancer that they've missed, and you want
no,
to? Okay.
I don't think that I have cancer. No,
Okay.
I just, all right. So the antihistamine is helping. Just be happy that it's helping.
Well,
All
okay.
right.
So if you want data,
Data.
okay, so if you want data, a next generation urine test will rule in or rule out fungal infection, bacterial infection, maybe even viral infection.
All right.
Okay. So if you want data, that's data.
Okay.
Okay. And,
Right.
you know, I mean, so I went through a period, not quite like 18 months ago, where I started getting vulvar burning. Oh, wait, this is really good for you. This is a really good story for you. Okay. So, I started feeling like, so this was after my hysterectomy, about a year. And I started feeling like little pinpricks along my hairline of my pubic hair. Just like a little pin, like pinch, 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 pinch. And then it started getting, and it was only along the outer hairline, right? And then it started being more consistent. Pinch, 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 pinch. And it was enough for me to go, what the hell is this? And then slowly over that week, it started going inwards. And so I started having pinching on the inside the vulva, right? And then it just goes really bad. It's like, so I go to urgent care. I get an urgent care appointment, one of those 15-minute appointments with a gynecologist to rule out yeast. See this old doctor who should have been retired, is like 80 years. I'm not kidding, man. This guy looked like Santa Claus. He was old. He was on call, pulling up extra hours because his wife had cancer and he wanted extra money, but he was kind of long retired. Puts me up on the table. He goes, "Wow, you're red." I'm like, well, something's going on. It hurts like hell. And he takes a glass swab. He takes see, look at this. See, this is menopause. What do you put underneath a microscope? The little glass slide. It's a special word for it. He takes a little glass slide, pushes it in, drags it down my vulva, right? Like really hard. And I'm like going, oh my God. And he takes it out and looks at it in a microscope and he goes, well, I think this might be yeast. I might have seen some yeast, right? And I'm like, dude, you just like stripped the cells off of my vulva. If it's there, you would have found it. So he gives me diflucan and nystatin cream, right? Doesn't work. And now I'm just being hit by needles, random needles all over the place down there. So I go to my regular OBGYN and she goes, this looks like eczema. And she goes, do you wear a mini pad? And I'm like, yeah. She goes, it's the shape of your mini pad. I think it's a chemical reaction to your mini pad. So we stopped wearing the mini pad. Then that doesn't work. And then she goes, we did a punch biopsy. And she goes, man, this really looks like eczema. So we just need to pound the steroids into you big time. Well, a month later, it hadn't worked. And so I go, I want a referral to the pelvic pain specialist. She gets me on the phone. She goes, Jill, can you sit? And I go, no. She goes, you've got a pudendal neuropathy.
I'm so glad you brought that up.
Yeah.
I have not been officially diagnosed, but from the book you gave me, you referred to me, I definitely believe that's what it is.
Mm-hmm. Mm-hmm.
I'm going to go in 2 weeks. I'll be seeing a gynecologist.
So what was so interesting about that is 2 gynecologists missed it completely, but it was bilateral. Number one, it was bilateral. And the pin pricking sensation, classic nerve sensation. And it took her 5 minutes. It took her 5 minutes to go, I know exactly what you have. You've got a pudendal neuralgia. You have a history of pudendal neuralgia. And I had no clue that a pudendal neuralgia could manifest on the vulva. And she said, yes, we work with it every day. And so what they gave me was a lidocaine estrogen jelly to use. And she sent me back to physical therapy. Okay. And the physical therapy worked. So I think that might be something that's worth ruling out.
Okay. Well, thank you. And I'll let you know how everything turns out.
Okay. And for people listening on Facebook and YouTube, I mean, like, seriously, we'll talk about anything. So, if you're like surprised that we're talking about stuff like that, man, that's life with pelvic pain. No shame. All right. All right, Stacy, keep in touch. Okay. All righty. Julianne, let's come back to, wait. Oh, there you are. Okay. So Julianne, we lost you. Let's come back to you.
Sorry, my phone had died. I didn't realize that the plug wasn't put in correctly.
That's okay, hon. So I think we were at the point where we were talking about physical therapy and that it was expensive and that they've given you vaginal Valium suppository. Hello, Kelsey. Kelsey, I will unmute you when it's time. You're going to have to hang out just a little bit. We'll get to you. So the challenge with pelvic floor dysfunction is that until somebody can identify the muscle group, it's going to be very hard for you to get to the bottom of it, right? Okay. And so let me get my favorite model here. All right. So let me just deal with these really quickly. Put this back together. All right. So here we have the female pelvis, right? And if we took all the bits out, what we have underneath are the pelvic floor muscles. And the thing to understand about the pelvic floor muscles is that your pelvic floor goes from left to right, front to back, and low to high. Okay. So it's not, when the word floor is misleading, it's not like it's flat on the bottom. It's not flat on the bottom. And if you can kind of see here, you can see that it goes up the sides of the bones, right? See, so you've got, and so when they do their pelvic floor assessment, that's what they're going to be doing. They're going to be touching muscle groups, left side, right side. You've got shallow muscles, mid-level muscles, and deeper muscles. And it's important to try to figure out which muscle is the problem. Because until you know the name, and then once they tell you the name, you can then go to YouTube and find there's a ton of physical therapy videos to get an idea of what you could do. And the physical therapist should tell you what to do. And then maybe you could go back in 6 months and get an update. But more importantly, we've got to figure out what not to do. That's the thing, is we don't do Kegels, because a Kegel will tighten muscles that are already too tight. And that's something that a visit with a physical therapist can at least give you a clue of what your options are, right?
Okay.
Yeah. But this is good news. Remember, in the Chris Payne subtyping system, when he created his 5 subtypes for IC, one of the things that he railed on were the number of patients who were told that this was incurable. And he said that is absolutely not true, that patients with pelvic floor issues are potentially curable because muscles respond beautifully to muscle work. And we have the research released in 2008, which shows that pelvic floor physical therapy is stunningly successful at reducing the symptoms of IC, frequency, urgency, pressure, pain. Okay.
One thing that I can tell you is that my urologist did a cystoscopy last Thursday without any numbing medication, no nothing. And I felt everything, and it hurt so bad.
Did they just do a cystoscopy, or did they do a hydrodistension with cystoscopy?
They did a hydrodistension with cystoscopy.
No.
And I was in tears.
Wait.
The pressure and the pain.
So they were filling your bladder with fluid as you were, wow.
With water while I was awake.
Well, was it a urodynamics test where they slowly start to fill it, and then they ask you, when do you first feel the need to pee? When do you first feel pain? Or did he just straight out want to fill it up with fluid?
They just straight out filled it up with fluid. And I was in tears.
Wow, I'm so sorry. That happened to me once too. And I mean, seriously, you're hysterical. It's like, stop, whatever you're doing, stop it, leave me alone, right? Was the doctor responsive? And when you said it hurts, it hurt. Yeah. Did they stop?
He was responsive.
Good.
She stopped, yes, but I was in pain for a few hours after that. Yeah.
Well, it sounds like she stopped early enough not to do any permanent damage. But the more important question is since you had it done, what did they find? Did she find anything interesting in your bladder?
She didn't. She said that it was just really, really irritated.
Okay.
And inflamed.
Okay. So remember, chicken versus the egg, which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? They're both involved. In you, they're both involved. You have an irritated bladder wall and you've got pelvic floor dysfunction.
Yeah.
And
I also ruled out that I have my left leg longer than the right leg.
Okay, good. So your legs are level. Okay. So your next step is a pelvic floor assessment. Let's see what we got. And in that process, just understand that the point of that first appointment is to gently touch muscles. And if she can touch a muscle and trigger your symptoms, that is your hallelujah moment. That is what are you touching? That's it. And for all we know, this could be an old legacy, a legacy injury from, when you fell down the stairs, right?
Yeah.
And muscles respond beautifully to muscle therapy. But in your case, understand that you may have had these tight muscles or messed up muscles or scar tissue for a decade. And so it's not like it's going to go away overnight. It's going to take consistent work on your part, on the physical therapist part. And again, you've got to learn the anatomy. I want you to be able to walk into that doctor's office or the physical therapist's office. And as you're laying on your back, I want you to be able to visualize what she's talking about, what she's touching. It's like, is she touching a levator? Okay, I know where that is. Is she touching my piriformis? Okay, I know where that is. So that you really, remember, like a 3-sided box open in the middle. And we have to be able, you have to be able to visualize where she's working so that when you start working there, you can work in the same area. And undoubtedly, you talk to her about him or her about a glass wand, using a wand yourself. So that's what I use. That's what most people, once you've been through it a couple of times, you start to recognize when your muscles are getting tight. So like I had a pelvic floor spasm last week. It's like laid in bed for about an hour going, damn it. Why now? You're just, grr. And it's like, all right, get out of bed, go get the wand. And I actually did the wand twice. I did 2 treatments over a period of about an hour and a half just to try to, and my muscles were shockingly tight. So I want you to be able to do that because that will help you control that a little bit more. Okay.
Okay.
All right, hon. Good luck. This is good news. I like this. Okay. All right.
Thanks.
You're very, very welcome. All right, Carol. So I've got Carol, Colleen, and Kelsey, but I think Carol came in first. So I'm going to go to Carol. If I got that wrong, don't take it personally. I'm just doing my best. Carol, are you here?
I am.
Hello, hun. How are you doing today?
Well, I'm laying in my bed with a heating pad, if that tells you anything.
Uh-oh. What's going on?
Well, I am constipated. That's not helping matters.
Okay.
But I feel like I'm a little bit of a flare also. But
okay.
I have, my most problems that I deal with is the frequency and the urgency. I mean, I feel like I could sit on the toilet all day and just pee a little, every few minutes, because when it takes a while for me for the urine to come out, and then it doesn't come out in great amounts. And it's because I have a girlfriend. She calls me all the time on Messenger with the video. And I'm always on the toilet. She's like, "Why are you always on the toilet?" And I'm like, "Because I feel like I could live here. I think I should change my address."
So Carol, how old are you?
61.
Okay. That as we get older, and with the loss of estrogen results in a loss of muscle health and muscle strength in the pelvis. And so what happens is our muscles just, I don't know, I don't quite know the right word to use. I call it milking my bladder. And I started doing it in my late 40s, where you go to the bathroom, you think you're done, and then it's like, nope, not done. Go a little bit more. Think you're done. Nope, not done. All right. 3rd time's charm. Then you stand up and go, nope, not done. Sit down, be a little bit more. Yeah. And that is that helps us understand that your muscles are potentially part of this problem. What you should not be doing is sitting on the toilet. Number one, you should not be straining in any way. You should not be straining to get anything out. And if your muscles are tight, it's going to cause constipation anyway. You know, because you're, you know, if I don't know, are you watching on video? I can't see you, but can you see me?
I can see you.
Okay, good. So I want you to I'm going to hold this up. So hold on a sec. And you don't have to turn on your camera. That's okay. So here we go. These are, that's okay. So remember 3 layers of muscles. We got deep muscles. These are the medium muscles. And then I'm going to put on the levators. Here are the levators. So these are levator muscles. The levator muscles in a woman have 3 holes in them. They've got a hole for the rectum, they've got a hole for the vagina, and they've got a hole for the urethra. And so this is the only major muscle group in the human body that directly controls other major bodily functions or influences other major bodily functions. Because if these muscles are weak and loose, you're going to be incontinent and have a prolapse. If these muscles are tight, it's going to be hard to let urine out. It's going to be hard to have a bowel movement, and it's going to be hard to have sex. It's going to be hard to, you know, have a penis come in your vagina or a speculum, because everything is very, very tight. So, have you
go to therapy and had a pelvic floor evaluation?
Yeah, and what did they find?
I don't know exactly. She said, yeah, definitely that my muscles were tight, and I used to go in for treatments, and I did buy the wand. I have yet to use it. And then when COVID came, I stopped going to physical therapy,
Well, yeah, but the most important part of physical therapy after the initial exam is what you do when you get home from the physical therapy appointment. It's about our ability to intuitively recognize when our muscles are starting to get tight and what we can do proactively to nip that in the bud. And so I think you might have given away your power just a wee bit, my friend. You've got a wand. You've used the wand before, correct?
No, I haven't used it yet.
You've never used your wand?
No.
Okay.
Go on YouTube.
Well, no, the challenge with doing the internal work yourself is just like, until you understand the anatomy, it's just like you're poking and prodding yourself and you don't really know what to do.
Right.
And that's how I felt for 2 years. I mean, it's like, okay, I'll try it, but I don't really get it. And what my physical therapist kept saying is it's a J shape, but I didn't understand a J shape. She said, move the wand in a J shape, like this or like this. And I'm like, I don't get it. I'm just sticking it in there. I don't know. And it wasn't until I got this book, Breaking Through Chronic Pain, where I really understood what the J shape is. And I can actually demonstrate it. I can actually demonstrate it here. So again, so I'm going to put my finger where the vagina is. And if you can see this muscle right here, it's a J shape up. It's a J shape up along the length of the muscle. See that? It is a J shape, just like that. And so the challenge, though, is you don't know where to work because you don't know which muscle group is involved.
Right. Yeah, it's been a while since I've been there. I should probably see if they're back open now and get another appointment.
Okay, so what I would do if I were you is, number one, I would definitely make another appointment, and let's see, because you should not be sitting on your toilet all day trying to pee. And for God's sake, you should not be straining in any way. If you are straining to try to get urine out, you're You're only making your muscles tighter. So that's concept number one. Concept number two is that if your urine, okay, at your age, you're going to be showing some estrogen atrophy. You're definitely going to be showing some estrogen atrophy, right? And
Yeah.
so I have to wonder too, since you're experiencing this every day and you're feeling frequency, urgency every day, right? Enough that
Yeah.
you're sitting on the toilet all day, every day. Is there something in your daily life which is irritating the hell out of your bladder wall?
I
And
don't know.
well, let's figure it out. So do you drink coffee?
I don't.
Do you drink?
If I drink it, it's decaf.
Okay, but even if it's decaf, when was the last time you had a cup of decaf?
Yesterday.
Okay, so I need you, in my opinion, you need to stop coffee for like 2 weeks.
Mm-hmm.
Just give it a break. Let's just try to calm the bladder wall down, because something is seriously going on with your bladder wall also if you've got frequency urgency. Okay, do you drink tea?
I do.
What kind of tea?
Either that, like chamomile.
Okay, is it just chamomile? Are you only drinking chamomile, or are you doing something else too?
It was just chamomile. There was also that throat coat, but my nutritionist told me I shouldn't take that because I'm on high blood pressure medication and it has licorice in it and interferes. She suggested, was it marshmallow root tea? Something like that.
So marshmallow root is viable, but it does flare about half of the people who try it. The chamomile's great. Peppermint's great. Licorice, if you do too much licorice, it can change your heart rhythm. So that's not going to be viable for you. So try to stick with the chamomile, the peppermint, okay? And if you want to try the marshmallow root, that's fine. But I would not for a couple of weeks. I would stick with the chamomile because we know that that's a nice, smooth muscle relaxant and will help your bladder wall. And Caitlin, if you can just hold on, let me finish this. Okay. Do you take a multivitamin?
I do.
What multivitamin do you take?
It's I think it's nature made, maybe, but it's for women and there's no iron in it because I also have chromatosis.
Okay, so it's a nature made. So let's look it up. Let's just look it up real quick because I have a feeling it's the vitamin that's killing you right now. So give me a quick sec. So it's a nature made women's multivitamin or women's multi 50 plus. What's the name? All right. So let's look at this. Yeah, honey, no. If I were doing this every day, I would be on the toilet just like you. There's just no way. You can't do that. That's not appropriate for somebody with bladder wall irritation. And that's probably why your bladder is hitting you so bad right now.
I really just started taking those. I'm not very good at taking vitamins.
Okay, but
anyway.
yeah, but I see patients in general, anybody with Hunner's lesions or bladder wall driven or estrogen atrophy, you cannot do a conventional multivitamin. They're too acidic.
I think, don't you sell one that has no iron?
We do. We have Bladder Smart.
Does that have iron in it?
Let me look.
Is that sort of like a multivitamin?
Yeah, it's a low acid multivitamin. There's no iron in it. But you can take iron separately. It's the ascorbic acid and the B6 that's a problem, hon. So with with the symptoms that you're having, it really suggests that there's something in your daily environment every day that's poking at your bladder wall. And it's got to be the fact that you've got estrogen atrophy, your bladder can't defend itself, and you're putting at least 2 acids on it a day. You're drinking coffee because decaf coffee is acidic too. And right now your bladder's fragile, but so you're putting coffee on it and you're taking a multivitamin. And so you could.
My doctor gave me samples for Inter-Rosa, and I haven't used them. Would that help with the what is it?
The estrogen. It might. It certainly might help with some of the estrogen atrophy, but you've got to think about your bladder as being irritated and traumatized right now. Think of it as being wounded. Okay. Yeah. So, hon, you could be a new woman 2 weeks from now, but you got to lose the coffee and you got to lose the vitamin for at least 2 weeks. Give your bladder an opportunity to calm down, and let's see how you do. But 2 weeks might not be enough. You might need to be really pristine with your diet for like 3 months, really give those tissues an opportunity to recover, and then for the Inter-Rosa to start working before you're going to be able to tolerate the decaf coffee. And then when it comes to the vitamin, you really need to do a low acid vitamin for that to work for you. Okay.
Okay. And you think I should look into making another appointment with my physical therapist?
I would. Why not? I mean, it could be either or, and it might be both. It might be that your bladder is so fragile right now because of estrogen atrophy that everything's hurting it, and your muscles are getting tight in a reflex. Or it could be the opposite. It could be that your muscles just continue to stay tight, and that's starting to affect your bladder again. Either or. You've got to follow both lines. Okay.
So you don't think I should just go ahead on, YouTube and start off that way? I mean, she showed me initially how to use the wand.
Yeah.
That was a long time. That was months ago. So I wouldn't probably know how to use it properly and on what muscles, like you said.
Yeah. Well, you're going to need help. You're going to need help to try to figure it out. You just do. But we can't leave tight muscles there. Tight muscles will, over the long term, impact the ability of the bladder to function normally because it's restricting blood flow to the bladder and to the vulva and to other organs. So if you've got tight muscles, we got to take it seriously and work with those muscles. I mean, we knew in 2008 when the first federal study came out, it proved the pelvic floor physical therapy was more effective than other bladder treatments at reducing the symptoms of IC. And so pelvic floor physical therapy is a game changer.
Yeah, my doctor put me on Mebetric, and I felt felt worse, like you had to push out more. And then lidocaine installations, they didn't do any good.
I know, but seriously, if you're pouring, you got to understand this. If you're pouring acid on the wound every day, the wound will never heal. There's no chance of a therapy helping you if you're pouring acid on the wound every day. There's no therapy that can counteract the damage done by that coffee or that vitamin, And so, yeah, I have a very famous story that at least it's famous in my mind, my small mind. I was working with a lady who called and spent a lot of time with her over the phone. She kind of a hysteric, you always know when you're talking to people, there are people that are very animated and kind of shrill versus people that are very kind of mellow. She was very shrill and challenging to talk to. And I spent a lot of time with her, explained the diet, and I never forgot her voice. And she called me back 5 years later, and she was just miserable, in agony. And it's like, all right, hon. Okay, so hold on. Let's talk about your symptoms. We went over her symptoms. Her symptoms were clearly bladder wall symptoms. There's no doubt about that. It's like, okay, now I know I talked to you about the diet. Are you following the diet? And she goes, yes, of course. No, her husband was on the phone. He goes, no, she's never followed the diet. She drinks a pot of coffee and a 6-pack of Diet Coke every day. And you should have heard her. She lost it on the phone. She started screaming at him. She started screaming at me. And she was just saying, I'm not going to let this rob me of something I enjoyed. I don't want to live if I can't have my coffee and my soda. Right. I mean, she was really, really just overwrought. And I said to her, okay, hon, I sent you to one of the best doctors in the country, Robert Moldwin. Did he tell you about the diet? She goes, yeah. I said, did you not believe him? She goes, no. And I said, I told you about the diet. You didn't believe me, right? No. every doctor you saw, you've seen what, 5 or 6 doctors, they all told you about the diet, right? And she goes, yeah. And I said, you never believed any of us, right? She goes, no, it never applied to me. She never believed it applied to her. And so I said, okay, how much money have you spent in the last 5 years on your IC treatments? And she said about $50,000 because she'd even had InterStim. And I said, do you realize that you have sabotaged every single one of those treatments? None of those treatments had a chance to work for you. None of them, zero. Nothing would work for you. And that stopped her from, she went, what? What? And I went, you sabotaged it. None of all that money you just wasted. And she's like, what? And I said, think about it. You have a wounded bladder and you're not just pouring one acid a day on it. All you're doing is pouring acid all day on it every day. You're not even drinking water. You're just drinking coffee and soda. That will wash out and damage. It will wash out any therapy you're trying to do, and it will just perpetuate damage and make it worse and worse and worse and worse. And she was like, oh. And her husband was like, I told you. You know, it was like, well, my answer was, and I told you too. And she's like, oh, right. And I was just very honest. I said, hon, you're addicted. You're addicted. You got a caffeine and you got a sugar addiction. You do. And she's like, you're right. I do. And I said, you're, you know, it's clear. She called me back 3 months later. And she went, Jill, you're not going to believe it. And I was like, what? She goes, I stopped it all. I stopped the coffee and I stopped the soda. And guess what? I'm better. I'm better. And she was stunned that she was better. And so, you know, she did not understand the mechanics of healing. She absolutely was IC subtype 2 bladder wall driven, estrogen atrophy, if I remember correctly. And she simply did not understand that she was pouring acid on the wound every day. And I think to a much lesser extent, and that her story is something that we can all learn from. You're kind of doing the same thing, but I'm not saying you're an addict. You're not addicted to vitamins, but it's just what vitamins do. They're irritating. Yeah. So I say lose a coffee, lose a vitamin for a couple of weeks, and let's see what happens.
I can do that.
You know, I mean, unless you've had a doctor tell you absolutely must take that vitamin for a medical reason, you know, it would be a very interesting experiment to lose a vitamin and lose a coffee and just see what happens. Okay?
Okay, but I just wanted to tell you that I'm so glad that you and your family are safe.
Thank you.
And that your house didn't burn down. I was so worried about you. It's really mean a lot to all of us. You give us such support and we really appreciate it. And I was just so worried about you. You're going to see it on the news all the time. My son lives in LA. Oh my God. Crazy.
Well, I'll tell you, for any of you saw the fires, you know, you see the fires on the news if you're back east. It's so much worse. You know, and
I can't imagine.
Oh, it's just, I never in my life thought that I would see fire coming to my house so quickly that we barely got out. And it's a miracle that the house, the fires got 3 houses away from my house, and we were saved by a bulldozer crew. You know, but the other really big issue is the smoke. So we got back 4 days later that we had massive smoke damage in the house. We still have smoke damage in the house. I still smelled it this morning. The air quality was anywhere from 300 to 500 for a week. So we couldn't air out our house by opening the windows because the smoke outside was worse than the smoke inside. So my suggestion to everybody is make sure you have at least one air purifier. I was running 4 air purifiers, and they're still set up. So anyway, thank you for your very kind words, hon. I really, really appreciate that. All right, hon.
When I was a kid, so I understand.
Yeah, you keep us posted, okay?
All right, thank you so much.
Okay.
Okay.
All right. So, Caitlin, I know you've got good news to share, but Colleen and Kelsey came in first, okay? So I'm going to go to them before I come to you. And then I've just let Brooke into the room also. So let's go to Colleen. Colleen, are you there? I have to unmute you. Colleen, are you there, Colleen? You can try to unmute yourself. She might have walked away. Colleen, can you hear me? All right. So I'm going to leave you there, Colleen, and I'm going to come to Caitlin. Oh, no, I'm sorry, Caitlin, not you. I'm going to come to Kelsey. I'm sorry, Caitlin. I'm sorry. Kelsey, are you there? I see your picture. Can you? There you go. Hey, how are you today? Okay, I can't hear you. You want to make sure your microphone is on? Testing 1, 2, 3. Okay, you keep unmiking. Let's see, you're blocked right now. I'm going to unmute you again. Okay. Oh, she says 1 second, be right back. Okay, she's going to try to log back in. Let's give her a moment. Let me try Colleen again. Colleen, are you there? Nope. All righty. All right. I'm going to come to Caitlin. Hello, Caitlin.
Hi, Jill. Thanks so much for hosting this every week. I just wanted to say it's helped me so much over the years. I really, really appreciate it.
You are very welcome.
Thanks.
Now, you say that you have good news to share. What is your good news?
So, my good news. Well, I have the main good news, but just to like speak back to what you were saying to Colleen, when I first was diagnosed and then found you and these meetings, you had told me about the diet, which was if you can't rub it in a paper cut, don't eat it. And I just lived by that. And when I first had my initial cystoscope when they diagnosed me, because mine's bladder wall.
Okay.
No Hunter's lesions, but there was like spider webs of inflammation and some broken blood vessels and stuff. And that was about 18 months ago. So I am now in, this is the good news part, a clinical trial.
Ooh.
I know. And so they did my initial cystoscope for the clinical trial. And the only thing I've really been doing, aside from the occasional azo, is the diet. And the doctor told me that the bladder lining looked beautiful.
Ooh, nice.
Yes. I was like, oh my gosh. And then even looking at it, the inflammation was visibly, significantly not as red, And so for anyone wondering about the diet, the proof is in the pudding. You know what I mean?
Yeah.
If you have a bladder wall based IC, it is real. It's like you have a paper cut, millions of paper cuts inside your bladder, and if you treat it that way, then what happens. It'll heal, and it does. The other thing about the vitamins, she was saying, I never take a multivitamin. I only take like one at a time vitamins, so that you know what they are, so that you don't accidentally get ones with citric acid in it.
Right.
So like I take a magnesium. I make sure it's just magnesium. If I take an iron supplement, I make sure it's only iron. And you're taking a fistful of vitamins every day, but you know what? You're not inflaming yourself every time you do it. If you want to be able to take supplements, which it's not always a bad idea. So the really exciting thing then is, so it's sponsored by the Saigaku Corporation, and it's called SI-722. And what they did was, I have all the information pulled up. It is, SI-22 is a chemical compound, which is a steroid conjugated with chondroitin sulfate using glycosaminoglycan.
Okay.
Modified technology. So basically, it's a sugar compound that is married to a steroid, which makes the steroid break down slower. And I am the first test subject to get this installation. So it's by installation. And I had my installation on the 15th of September. Mm-hmm. And they gave you, to get into the study, they had you take these questionnaires about your symptoms. So they had a grading system. And for your grading, the grading system to get into the study is you had to have a score between 15 and 30, and I had a 27 of my presentation of symptoms. So then the first follow-up after the installation, 3 days later, my symptoms were down to a 13.
Wow.
Then my second follow-up, 2 weeks later, my symptoms were down to a 5.
Oh my God.
So it really is working. And I, when I stay 100% on the diet, I, for the first time, can honestly say I peed with no pain.
Oh my God. So a lot of people don't understand that the bladder, that the glycosaminoglycan layer up at the top of the bladder actually has it has sugar structures. And so I pulled up the study. I'm looking at the study right now. So the study it's recruiting at
that was the next thing.
Yeah. So it's recruiting in California and Los Angeles at the American Institute of Research, the Tri-Valley Urology Group in Murrieta, California. It is recruiting in Florida at the Villages at Premier Medical Associates. It is in Garden City, New York.
That's my location. They're so lovely.
Yeah. And Centex studies in Houston, Texas.
Mm-hmm.
Oh,
so they are having trouble recruiting women or men with IC because part of the study is, over the course of the whole study, you have to do 3 cystoscopes. They do give you numbing gel, so it's not totally horrible. And life hack, if you're getting a cystoscope, before you go in, buy Dermaplast spray. Dermaplast spray is numbing spray that they give to women after childbirth to not inflame them. So if you spray your vulva with Dermaplast spray during a flare, it alleviates the pain and the urgency after you just finish peeing. It's very affordable. It's in every CVS. It's $8. And if you put it on right before they do the cystoscope, it kind of numbs it so much so that the initial entry of the cystoscope really, it's as low of an amount of pain as I ever felt during a cystoscope. And I've had my share of cystoscopes.
Nice.
And then over the course of the study, you have to do 2 more cystoscopes. One right after the installation, and then one 5 weeks later.
Okay.
So I still have to do my one 5 weeks later. But apparently when people are coming to sign up for the study, they'll make it like almost all the way to like get into the study, and they'll find out that they're cystoscopes and they all run for the hills. But
Well,
they do $1,800. So it's not like you're doing it just for for fun and laughs.
So if you can let the doctor know that we do clinical trial recruitment and that I can send the announcement out to 30,000 patients, if they would like to promote it, sometimes the company will step forward and do it. And then we can just, we haven't done in the last year, there have been very few clinical trials. I'd be more than happy to work with them. If you want to give them my name and number and tell them that we've done the clinical trial recruitment for almost all of the major IC research studies. And we're very good about filling studies. So I'd be happy to spread the word, especially based upon your testimony. And they've actually now gotten an announcement about this study, for people watching here. So this is good news. And let them know, and they can just call me and I'd be happy to talk with them.
Amazing.
Yeah.
So I was literally patient 0 to get on their study. I was like, who else got it before me out of all the locations? She was like, one of the women, Tammy at Acumed, she was like, nope, you're number 1. You're patient number 1.
I love working with studies. I tell every single one of them that the reason why I work with you is because you represent hope. You're showing that the IC movement is vibrant and alive and kicking. And for patients who have tried a lot of stuff and they feel like there's no hope, I always say, no, that's not true. There's always hope, because we always have new therapies under investigation. And the nice about participating in clinical trials, especially for patients who are low income, is that your medical care is free, and you often have the opportunity to work with some of the best IC doctors in the world. And so clinical trials are a wonderful thing to think about doing. I usually, in my newsletter, I highlight, I usually at least twice a year, do a list of all the active clinical trials. And then, and so thank you for doing that, because I will put this in my next newsletter. But
and Dr. Mitchell Efros is the doctor that they've partnered with at Acumed in Garden City.
Okay.
And if anyone in the New York area needs an IC doctor, he is wonderful. Absolutely wonderful and lovely. And I would also say that I can, like, a couple of times a week have a cup of coffee now.
Wow, that's exciting.
I know. Coffee.
So
milk, coffee, like not low acid coffee, not decaf, like actual coffee, and did not give myself a flare. I was able to have a slice of real pizza with tomato sauce.
Wow.
The only two things that really put me into an actual flare is like citrus and vinegar. And even those flares that if I was pre-study would get like a 9 or a 10 on the pain scale of a flare, now it's like a 6 or a 7.
Oh.
Which is still a flare, but it's a flare that you could treat and like get on with your day after.
Yeah, but the thing is that what it's showing you is that healing is possible. Things are happening, and that should give you comfort and give you hope and give you confidence that the good things are happening, right?
Exactly. Like so much hope. And I'm just like, I want to scream it from the rooftop so people can sign up, because the more people who sign up and do the study, the quicker that they can get it to the next levels and eventually put this on the market, because this is game changing.
Love it. I love it.
Yeah.
And it sounds like it's fairly benign. I don't know that much about it. I will ask them a lot of questions, but I think this sounds fantastic. Congratulations, hon. Thank you for sharing your fabulous good news. And if you could, I would love to stay in touch with you, especially maybe towards the end of the year, so that we can maybe give an update on how you're doing to give other patients hope. Let's give it a little bit more time. You've only had a few. Let's see how you're doing after, 8 sessions or something like that. Okay.
So, well, actually it's only one session. You only do it. They only gave me one installation.
What?
And and it keeps working more over time.
Oh my God. Okay.
Yeah.
So
it's been almost a month and it's still working.
Oh my God. Okay. I didn't know that.
in the chat key, I just gave you my email.
Yeah, I got it. Yeah, I got it.
And I could put Acumed's phone number in there too if you want to get more information.
Okay.
They're lovely. Tammy was the one running this study. Her daughter has IC, so I think that was part of why they took it on.
Okay.
Tammy Allegra, she's absolutely lovely. So I chatted you, Acumed and Tammy, over there.
Okay. Thank you. Yeah, I got that right here. Let me just write it down while I can.
Dr. Mitchell Ephros.
We should do a story on that anyway. I try to do that. It's been a very rough year.
Oh no,
for all of us. So
yeah.
So let me just write this down. Girl, thank you for sharing. I love it.
Yeah. So it's something that I was like, I've called in for before and had like, bad news and needed tips, but right now it's like I feel like I'm just so excited to share this with people who could maybe see the same results.
Awesome. Okay. Yeah. Well, I will definitely do a story on it. Okay.
Yay.
Yay. Okay, hon. Keep in touch.
I will. Okay.
You have a good day. Okay. Bye-bye.
Bye.
All right. Our last Zoom person is Kelsey. Let's see if it works.
Is it working?
It is working. Yay. All right, Kelsey, how are you doing today?
Pretty good. I've actually been, I went on Lexapro because my anxiety was so bad and it was just making my pain worse.
Okay.
And since I lowered my anxiety, my pain has gotten a lot better and I've been doing my speeches with physical therapy.
Yay.
Everything's good. I just had a question and I didn't know if you had the answer. Sorry, my kids are in the
It's okay. We're good. We're children friendly here.
I didn't know if Peora was safe to take with an SSRI.
I don't know.
Okay.
Palmito ethanolamide has been used for a couple of decades over in Europe for chronic pelvic pain. So what I would tell you to do is I would go to pubmed.gov and search for the active ingredient, palmito oil ethanolamide, and go through a bunch of studies to see if anybody's talked about it. And then I would also look up the SSRI. I would go to drugs.com, look at the SSRI, and see if they have any drug interactions listed.
Yeah, as far as my research took me, it didn't seem to have any interactions, and it looked like it was going to be fine. But,
Yeah, I mean, I don't know enough about the mechanisms of action of what you're doing to. I can't give you medical advice on that at all. I would just say, go to the drugs.com and look at what they're saying for drug interactions, and then look at the PEA studies and see what they say. That's what I did when the whole PEA-IC research came out. I mean, I knew about PEA. I've known about PEA for about 10 years. But when the IC study came out, I just dove into the research and I was looking for side effects. And what I found was very, very few side effects reported in the studies, at least about the 20 studies that I looked at. Okay.
Yeah. I really want to try it. Just I'm actually having a weird thing. I went to the doctor and I told her about the book and I was kind of informing her about some stuff related to potential neuralgia and different things. And I'm actually having a period ever since August. I've been having a period every 2 weeks, and so I'm just not really sure what's going on with me. It's very weird. I had that surgery. I think I told you I had surgery in May, and I only have one ovary now, so I'm just like, So lots of weird stuff, but
I know, but a period every 2 weeks is absolutely not normal.
Right.
And so you would be making an appointment with your OBGYN. How old are you?
I'll be 30 in 4 days. Yeah, and I did lose 13 pounds from stress. I think it could be a multitude of things: my stress, losing weight, having a surgery. So yeah, I'm definitely getting in to see a urogyno, but this stuff is so complicated and everyone is different, and not everyone's the same.
Right,
So.
right. You are literally an anatomical mystery to be solved. No doubt about that. And so, well, okay. So, again, this is, I think your homework would be to go to drugs.com, or you can talk to your pharmacist, look for drug interactions, see if there are any known interactions. In the same sense, go over to the National Library of Medicine, pubmed.gov, and go through as many PEA studies as you could find. Look for adverse events, see if anything mentions anything about that. I'm not aware of any, but I don't want to lead you down the wrong path. And if you have concerns, you have to follow your instinct and follow those concerns. Okay, that would be my suggestion. And yeah, you keep turning your mic off and on.
Because my little one is sitting right here, and I'm like waiting for him to just squall. But
Oh,
yeah,
it's okay.
Thank you so much for the help, and I'll let you know if anything comes up, just so you can have that,
Sounds good.
repertoire.
All right, hon. Well, you keep me posted, okay? You have a good one, and thanks for coming into our Zoom meeting today.
All right, thanks.
Okay. All right, I'm going to shut down Zoom. That's it. Zoom is over. The Zoom meeting is now shut down, and let us come back to Facebook and YouTube. Hold on. All right. And so somebody's saying, is this live? Yeah, this is live. We've been going on for 3.5 hours now. So we've been dealing, so you guys, we're simulcasting live, we're simulcasting on YouTube and Facebook. And on YouTube, we have been working with Mickey. And Mickey, I don't know if you're still here. So Mickey has been dealing with very intense symptoms. And because intimacy is painful, her partner has drawn a line in the sand. And so the question is why would her muscles consistently be tight? And we always go back to what we call a mechanical injury. Is there some sort of mechanical dysfunction? The author of this book, Dr. Jerome Weiss, and guys, again, I'm just going to say this right now. Anybody with muscle issues, anybody with any history of trauma, this is the book to get. This is such a good book. So Dr. Weiss practiced in San Francisco for his entire career. He's 81 years old now. He spent 15 years writing this book. And this book literally is a love letter to pelvic pain patients because he wants you to have a lot of things to explore. Because many times when you go to a doctor with chronic pelvic pain syndrome, they just say, hey, take an antibiotic, or it's all in your head, or all that sort of stuff. And he's giving you a roadmap. He's giving you all the different things that we know can contribute to this. So one of the things that really baffled him in his practice is he became a master at muscle work. If you walked into his office with a trigger point, you would walk out without a trigger point. He is a master at dealing with tight muscles and also a master at calming nerves down. But what baffled him is if you came to it, let's just say you walked into his clinic and you had trigger points along your left piriformis muscle as well as sciatica and pain on your left side, which is what I have, right? Okay. He could end that appointment, massage that out, and get your muscles normal. But what baffled him is why did the trigger points come back in exactly the same spot? And why were the muscles tight in exactly the same spot? And he's the one, and you know, I always love reading. It's interesting. Being in my job's really interesting because you have to remember that some of the old time IC doctors are very old school, and getting them to look outside of the bladder is really hard. And I started using the word injury 15 years ago, and you know, started saying, okay, let's look beyond the bladder at other stuff. And so, of course, he did exactly the same thing. He said, all right, let's take a step back and let's see if there's any sort of skeletal dysfunction, a problem with a bony structure that is tweaking these muscles out. And so it makes sense that if you have a bad hip, that's going to tweak your pelvic floor out. If you got a bad SI joint like I do, that's going to tweak your pelvic floor out. If you have a bad knee and you're limping, well, that's definitely going to tweak your pelvic floor, because the forces and stresses of you walking are directly reflected up your legs, up your muscles, into your pelvis. If you jump and you land on 2 feet, all the forces of you jumping and landing in that weight absolutely end up in your pelvis. So if you have one leg longer than the other, then your hips are like this. And of course, that's going to put strain on one side of your muscles. But the chapter which blew my mind, and the big discovery that he made, was that 90% of the patients in his clinic with recurring long-term chronic pelvic floor tension had foot problems. They were not walking normally. And that's a problem. That's a problem, because if you're not walking normally, all the stresses get reflected up into your pelvis. And so once they got their feet corrected, the muscle tension stayed away. And so anytime we see somebody with long-term chronic muscle funky stuff going on, always want to look at bony structures and see if there's anything funky going on with those. So my dominant problem is on my left side. It is my left SI joint, and it is a bane in my butt. And the muscles trying to hold that joint together vibrate frequently every day. And because of COVID, I cannot go get the prolotherapy that we were going to do. And that is my next step. Although it's not vibrating right now, which is cool. Usually it's vibrating by the end of these meetings. So Mickey said she took the adverse events for her doctor wanted to do InterStim, but she took the adverse events she found at the PubMed database. I mean, at the MAUD database. Yeah, and your doctor didn't like seeing those, huh? Thousands of adverse events reported with InterStim. He says you're one of the worst patients. He wants to do hydrodistension fulguration biopsy. Well, if you still have Hunner's lesions, we want to definitely try to treat those lesions. The question is maybe it's time to try something else, maybe hyperbaric oxygen therapy, or maybe steroid injection into the lesion instead of the ulcer. And the ankle stimulation that he wants to do, that's a no-brainer. I did that. I mean, that's neuromodulation, but without the surgery of InterStim. But if you're having bad sciatic pain down your tight leg, and you've had two laminectomies, L5S1, you know, so you've got some significant musculoskeletal issues going on, hon. You do. You do. Jan from Scotland had a course. Hello, Jan. Always nice. Always nice to talk to I see patients in Europe and in Scotland. I just saw beautiful pictures from Scotland. So she had a course of bladder installations. They helped. Awesome. Brick says, what is study information? If you ever want to find clinical trials for IC, we have a clinical trial center on our website, but I haven't had anyone to put up in a year. go to clinicaltrials.gov, clinicaltrials.gov, and that's where you'll find that study. And just make sure you sort it for actively recruiting. Otherwise, there's going to be a couple of hundred studies in there that are no longer recruiting. So just on your search terms, do actively recruiting, and that's how you will find that study. All right, my friends on Facebook. Lorraine says, "What about the knees, hun? If your knees are not normal, if you're having trouble with the knee, if you're limping, if you're straining on one side, that is absolutely going to influence your pelvic floor and potentially cause pelvic floor tension." Danielle says, are prebiotics okay to take without damaging the bladder? A prebiotic would not damage the bladder that I can see. The danger of probiotics, there's probiotics and prebiotics, if there is a danger, is that there are some people who take too many. And if you do too many, you're putting good bacteria back in your body. But if you do too many, you could potentially create an infection of too many bacteria. It's a healthy, the urinary biome is a healthy ecosystem of checks and balances. And if you overload one side, so be modest, be normal, don't go over the top. And I always say mix it up. I wouldn't take the same brand over and over and over again. Mix it up. Leslie from Australia. Hello, Leslie from Australia. Thank you for coming in. We have really rough roads. Sometimes after a drive, I feel that my bladder is sensitive. Is there a cushion I can purchase that will help on long car rides? Yes. Go over into our store, and I would be looking at the waffle cushion, which we have, and that's really good for, it puts about an inch of air between the bottom of your butt and the chair seat. So the waffle cushion is great. And then the other cushion is this one. Let me get it out of my closet here. So generally, the ideal cushion has a groove down the middle. So each butt cheek is supported, but there's nothing being pushed up right into your crotch. And this was a sample of the cushions that we had made for us. And unfortunately, they shut down the factory with COVID. And so we don't have too many of these anymore. This was a sample. Obviously, it's a little too wide, but it's just a sample. They said, no, I need to give that to my dad. My dad has a pressure sore down there, a little tiny pressure sore. These are CAPS cushions. So the cool thing about this is you can flip it either way, but the point is you generally want to have, you don't want anything pushing up into your tender bits. And so the cap cushion, this is a really high quality cushion, really good fabric. Whereas the blue cushion that we were selling, a third of the price, but they would only last you, 3 to 4 to 5 months before you'd have to buy another one, where these are going to last for a much longer period of time. So I would look at these CAPS cushions. And again, you can find them on our website, icnetwork.org. Why is B6 not good? You know what? I don't have the exact chemical explanation as to why B6 is not good. I can tell you that we've known for almost 30 years that patients flared with supplements that contain B6. B12 is fine. B6, not so good. Hi, Deborah. Elizabeth says, is there a list of doctors somewhere that treat IC well? Yes, on our website, icnetwork.org. Florida is a rough state. There are fewer resources in Florida. And so what I would suggest that you do is actually call the physical therapy clinics that work with pelvic pain and ask who they work with. Nicole's laughing with my use of the term tender bits. I know. Susan says, can you refer me to a doctor that lives for IC in Walnut Creek? Unfortunately, I can't. Even though I'm the Northern California IC support group leader, what I would tell you to do is there's a very good pelvic pain clinic, a pelvic pain physical therapist in Walnut Creek, pelvicpainrehab.com, I think. I would call them and see who they're working with locally. Let me make sure, Susan. Pelvic pain rehab. Let me hold on. Yeah, pelvicpainrehab.com. It's, in my opinion, very close to being some of the best physical therapists in the world for this. The founder is a former president of the International Pelvic Pain Society. They have several offices in the San Francisco Bay Area. They have an office down in Los Angeles, and they have an office in Massachusetts. And so also pelvicpainrehab.com. Let me just give them a shout out. Their blogs are amazing. They are so good. They're such good writers for men and women. The articles over there on that website are fabulous. And they do blogs every week. I mean, what do I say? You got to improve your knowledge level. You can count on the information at Pelvic Pain Rehab. Emily says, I'm not working at the moment because I'm basically bedridden. The only things I do are doctor and physical therapy appointments. Emily, I wish you'd come into the Zoom meeting. I'd love to hear more about that. See if we can help you a little bit. Okay, it's time for a giveaway for those of you who stayed. And our giveaway is going to be a bottle of Allopath. I'll give one away on Facebook and one away on YouTube. But this is going to be a slightly harder question. Now, I said at the beginning of the meeting 4 hours ago, I gave you the answer to this because we were talking about central sensitization and the nerves that sometimes get wonked out. So then, let me hold on. Now, I don't know if anybody's here that was here then, and if y'all wrote it down, because I told you it was going to be a hard question this time. So the type of nerve that delivers sensation to the brain is called what? And it starts with an N as in Nancy. Does anybody remember the name of the nerve that delivers sensation? No, it's not a neuro. Stacy, that's a great guess. A neurotransmitter is, in fact, the chemical that's released at the synapse, at the end of one nerve. It's released by one nerve, and it goes to the next nerve, and that's what makes nerves go. There you go. Nicole on YouTube got it, and Annie Chin on Facebook got it. Nociceptors. Nociception. All right, so Annie Chin, and Annie is on Facebook, and Nicole is on YouTube. So you two ladies, I need you to send me an email with your mailing address so that I can mail this out to you tomorrow. I've got 2 bottles with your names on them. And let's see. And that's going to be Allopath. All righty, my friends. Well, I'm impressed. That might have been literally one of the hardest questions that I've ever asked. That's obscure. But some of us are geeks and we like being obscure. But it's even a little obscure for me. All right, I'm going to take a quick bathroom break because I will be back and I have more energy for more questions. We're done. We're done. But if y'all have more questions, hit me. Okay, just give me a minute. The left pelvic floor, my left piriformis. Oh, so tender. It is tender. You know what I think I would like to do? First of all, does anybody have any questions on supplements? If you have any questions on supplements, I would be happy to give you the pros and cons on some of those. But what I wanted to do, so, somebody asked earlier about flares triggered by allergies. And I came back to our summer 2018 IC Optimist because every year I review the latest research and the latest classes taught on IC. Billy says, why does a urologist put you on macrobid for like 6 months? It sounds like they're doing it as a prophylactic to help prevent UTI, Julie. Of course, the challenge is that when you take a long-term antibiotic like that, you're actually damaging your ecosystem. You're damaging the urinary biome. And so the American Urology Association guidelines for IC specifically say that long-term antibiotics are not a treatment for IC in any way, shape, or form. So it sounds like they might be doing that to you because they think you might have a history of infection. What did they say? I wanted to just, I wanted to go over just a couple of case studies that were presented at this meeting because I think you'll find this interesting. Case study number 1. 31-year-old female with all the symptoms of IC, including painful sex. She was treated with antibiotics. There you go. How's that for some timing? Her gynecologist thought it could be endometriosis and treated her with Lupron. She was given a potassium sensitivity test, which was positive, suggesting that her bladder lining was damaged. But Elmeron therapy did not help. And multimodal therapies, bladder installations did not help. And she could not start her urine stream easily, and sex was painful. Dr. Rob Maldwin said, this is the classic patient that we see. She had elevated pelvic floor tension as demonstrated by urinary hesitancy. And he wondered why her other doctors didn't ask, why can't a young person void completely? He concluded that she has high-tone pelvic floor dysfunction and was treated with muscle relaxants, baclofen and vaginal Valium suppositories. She's also had pelvic floor therapy. She can now void normally and intercourse has improved, right? Okay, Tabitha says, is there anything to flavor water with artificial flavoring pack? No. The problem with the artificial flavoring packets is that they usually put in a lot of preservatives and or artificial sugars and or flavorings. If you're looking for flavor, I have another website called IC Diet Project, the icdietproject.com. And there are a ton of recipes over there and ideas over there. I've got one over there on how to make your own spa water with lots of different flavors. And then we've got other ones over there on other cool drinks. So Tabitha, go over to icdietproject.com. And then also, where is it? Do I have it here? The IC Chef Cookbook has a lot of recipes in there. But for the simple water, honestly, there's like nothing better than taking a sprig of mint and or maybe some blueberries or some raspberries and putting that in the water and letting that sit on ice for like 15 minutes and then enjoying that. But anyway, icdietproject.com. Oh, wait, what did I do with my thing? Oh, here it is. Yeah, the drop-in water packets are just, they just don't work for us. There's just too many artificial irritants and chemicals in them. All right, let's go to case study number 2. 72-year-old male with prostate problems. He was treated with antibiotics and alpha blockers with no success. He had a very tender rectum and a cystoscopy showed a normal prostate. This patient was diagnosed with severe high-tone pelvic floor dysfunction. He was treated with physical therapy, muscle relaxants, and trigger point injections. Dr. Evans said that it's quite common for patients to have both bladder wall and pelvic floor symptoms. He said it's like peeling an onion. They treat the pelvic floor dysfunction first to restore blood flow to the pelvis and to the bladder, and then they treat the bladder if it's still necessary. Bladder treatment may not be necessary in some of these patients. Isn't that exciting? That's really, really exciting. And think about those patients who you've been on bladder therapies for a decade or longer and you've never gotten better. Now we know why, because it's probably not your bladder. It's probably your pelvic floor or maybe even something else. He reminded the audience that pelvic floor dysfunction is essentially muscle weakness that can be caused by guarding from pain, a history of abuse or trauma, as well as generalized clenching. One surprising fact is that 75% of people who clench their muscles below the waist also clench their jaw, i.e. TMJ. He also explained why ejaculation can hurt in men. A vicious cycle becomes established when a man has a tight pelvic floor. This then triggers, well, anyway, it's obvious. It's a severe pelvic floor spasm. Let's go to case study number 3. 52-year-old female with uncontrolled urgency and frequency. She was treated with oral medications with no success. She was treated with bladder installations with no success. Dr. Evans said, frequency and urgency don't always respond to typical IC treatments. In these cases, Botox may be helpful. Successful submucosal Botox injections were performed on the patient throughout the bladder. Okay, let's go to case study number 4. 44-year-old female diagnosed with IC. Old school bladder installations did not work. The instructor said that a reasonable way to approach this patient is with a simple DMSO cocktail of Rimso. Oh, I got to say something about that too. I got something in the mail. Triamcinolone, heparin, sodium bicarb, etc. They note that with DMSO treatment, symptoms usually worsen before they get better and that the full effect might not be seen for months. Now, I'm just going to say right now, guys, DMSO is really fallen out of favor as a therapy. Remember, this is 2 years old. There you go. Case study number 5, 36-year-old woman with pelvic pain and IC. She has a long history of yeast infections and diflucan use. She only has 7 voids in 24 hours with no urgency or frequency, and her pain is primarily vaginal and vulvar. Her diagnosis was vulvodynia. She was immediately instructed to eliminate all vulvar irritants, such as scented feminine products, douching, soaps, dryer sheets, products containing acetyl alcohol, propylene glycol, benzalkonium chloride, benzoic acid, scented pads, and over-the-counter yeast meds. She was instructed to use unscented soap, ice packs, to take warm baths with Aveeno, and to use white Crisco, coconut oil, or natural vitamin E oil on these tissues. Additional treatment included compounded creams with lidocaine. Mrs. Fariello Moldwin said that she particularly likes using an aloe lidocaine jelly, such as the Desert Harvest Relivium, because it is less irritating and can be put into the fridge for a cool sensation. She said that cromolyn was the best for injury, but sometimes compounded amitriptyline ketamine creams relieve symptoms in many, many patients. All right. So that shows you absolutely the tremendous diversity in this patient population. You are each a mystery to be solved. Julie says, yes, I've had bladder infections that come frequently, infections. However, not much will show in the urinalysis. My gyne said it's because of my estrogen. Yes, that's true. So 14 days straight of Vagifem and Macrobid for months. But lo and behold, I have another flare. What now? See the urologist for a cystoscope? This is a pattern for me. Well, so Julie, it is absolutely true that if you are in perimenopause, menopausal, or postmenopausal, that reduction in estrogen is going to cause the thinness of your bladder. I mean, your bladder wall thinner. That mucosal barrier in your bladder becomes thinner, and normally it protects that tissue. It acts as a barrier. What I do with my thingy? Okay, but when you have estrogen atrophy, that nice thick coating gets thinner and thinner and thinner. And so what that means then is it's easier for bacteria to attach to cells. And so there is a group of women who absolutely do get recurring real bladder infections that are directly because of their age. Now, I attended a wonderful lecture on this by a guy named Anthony Schaefer years ago. And there were a couple of points that he made. Is number one, they never call it a simple infection. It's always a complex infection in somebody who's getting recurring infections over and over. The second thing is that in the research that they did, they studied urine every day. They did vaginal swabs every day. They did rectal swabs every day, trying to figure out why the heck women keep getting these infections. And what they consistently found was that about 24 hours before it arrived in the bladder, it was living quite happily in the vagina. And that then had the researchers then had to ask, well, why has the vagina become a safe haven for bacteria? What has happened to the natural defenses in the vagina? And the answer comes right back to estrogen atrophy. So normally, not only will they give you an antibiotic, they will also give you an estrogen product to use vaginally to try to restore some of those defenses in there. And normally that's for, for a long time. It's not just 14 days and you're done. It's like using it because you're getting older and your skin's just getting drier. And so it's usually a long-term thing. Like I've been using my estrogen cream for 8 or 9 years, and I intend to continue to use it. So concept number one is improving your defenses. But concept number two is what's the bacteria? And the fact that you're having them consistently, the first question I always say is, what's the bacteria? Is it E. coli, staph, or strep, right? We want to know. Number two, is it the same bacteria over and over? Because if it's the same bacteria over and over, the first thing we got to figure out is there something in your daily environment that is inoculating you? Like, for example, a bathtub. If you have a bathtub with jets in it and the jets are collecting water and not draining properly, it's a well-known source for chronic recurring infection. But if it's different bacteria all the time, then we might want to look also at your immune system. I have a family member, as an example, I won't say who, but she might be listening, who has had real bladder infections for years. I mean, decades. And they finally figured out that she has an immune deficiency. And once they started giving her IgG, because that's where she was low, guess what happened? She hasn't had an infection since. She hasn't had a sinus infection or a bladder infection. So, Julie, it would be interesting to know if perhaps there might be an immune issue going on. That's possible. And then kind of last but not least, identifying the bacteria, especially if it's a drug-resistant bacteria, is really, really important. And a typical urine culture will not do that, but a next generation urine test will do that. And so eventually, I mean, once or twice is okay, it makes sense. But man, if this is recurring, I personally would want to know what the bacteria is. It's like, what the hell is going on? And the nice thing about the next generation testing is it doesn't try to grow bacteria. It looks at DNA, and it will tell you everything living in your urine. It will tell you good bacteria, it will tell you bad bacteria, and it will tell you if you have any fungal infections. And even more so, it then compares the DNA that it finds with the huge international database at the Center for Disease Control, and it will tell you what the drug resistancies are. And it will also tell you if you have any drug. I mean, like for me, I've had it done a couple of times. I have an amikacin drug sensitivity. And I mean, amikacin, drug-resistant amikacin bacteria in my urine. And I've never taken an amikacin antibiotic that I'm aware of, unless I was a baby. But I could have gotten that through food. So if you go to bladderhealth.org, that will give you, there's a bunch of videos there of doctors who use next generation urine testing. And in fact, we just had a big lecture at the American Urology Association conference this summer, which predicted that urine cultures will be out and that the future will all be next generation. It's $199. Some insurance pays for it. Some don't pay for it right now. You order it. They send you the kit. You then take a form to your doctor, ask for a signature. You send your urine back. Piece of cake. Super easy. And the data, it's just good data. Julie says, who diagnoses you for any of these problems that you talk about? You're a urologist or a urogynecologist or a gynecologist. Many gynecologists are very, very familiar with recurring UTIs in old because of estrogen atrophy. Chip and Karen say, are the installations still recommended with Elmeron, heparin, and lidocaine? Yes. If you're IC subtype 2 bladder wall driven, then yeah, doing a rescue installation makes sense. Julie says, my last culture came up with 50,000 to 100,000 Staphylococcus. Ooh. So what were the drug resistancies? Sensitivity testing to verify which is the best antibiotic to kill that bug? Did they give you a clue on that? All right, last call for questions, my friends. Last call for questions. Now, 2 weeks ago when I did this, I had no clue that my house would almost burn down. So I might have a little bit of PTSD tonight. We'll see. For those of you wondering, it's called the glass fire, like drinking a glass of water. And you can go to YouTube and watch the videos of the damage. It burned right through my neighborhood. It's awful. So they saved our house, but we we literally had to drive for our lives. The fire was very fast. No, okay, Julie says, no, they did not do antibiotic sensitivity. And then the doctor said I didn't have a UTI. Well, and then at the same time, Nicole over on Amazon said, next generation test results have shown bacteria, Enterococcus facialis, which is interesting bacteria, but you're having no symptoms. So listen, Nicole, remember that they have identified like 4,000 potential bacteria that can live in our urinary tract. Actually, I think even more than that. And so we are all a wonderful population of beneficial bacteria that keep us alive. And there are so it is our urinary biome, or it is our microbiome. So the thing is that there are going to be bacteria that are meant to be there. And so the decisive point is, we don't want you to chase bacteria where you keep getting tested and they find something else, and they keep testing and they find something else, and they keep testing, finding something else. I did a big interview with the CEO of Microgen last year. And I said, what's the deciding point? How do you know when to treat? And he said, if you're symptomatic and they find an overgrowth. But if you're asymptomatic, but they find a bacteria, you're asymptomatic, there's no reason to treat. You're not having symptoms. Chip says, what time do these sessions start, and are they every Sunday? I normally start them between 12:30 and 1 o'clock on Sundays, Pacific time. The fall season is hard for me to do this because of the fire season. They turn our power off frequently, and or we have fires, and we had the worst of the worst. We had a fire 2 weeks ago. And it decimated my neighborhood. My home was saved by a bulldozer crew. So I am back home. And so we shouldn't burn for another year or two, crossing the fingers, but life in California is getting complex. I think I'm going to start adding a second meeting a week. I'm very tempted to do Wednesday and Sunday. But what I might do is I might do YouTube on Wednesday, Facebook on Sunday, so that I can use my streaming software and show you more things like videos and diagrams and things that would be helpful. I was thinking about that this morning. Now that things are getting calm and my desk is getting clear and I'm almost done editing our latest book on IC, it's awesome. I'm going to have a lot more time to stream, and I want to stream. I love doing this. Julie says, what did you say prevent is? So prevent is like Ellura, E-L-L-U-R-A. It is a proanthocyanidin based supplement. That PACs are the active ingredient in cranberry that repel and prevent bacteria, but this is not acidic. And so Ellura is very common, but it's very expensive. It's like $120. And so the company that makes Bladder Builder and Bladder Rest was asked by the top IC research, Dr. Ken Peters, to make an option. And so this was at his request. And so Prevent is for people who struggle with recurring infections. Tons of people are buying it now. It's being prescribed. Except it's over the counter, it didn't have to be prescribed, but this is probably one of the most exciting supplements, along with Peora for pain relief. Stacy says that would be nice. Yeah, I want to do more. I would really prefer to be over on Twitch. If we were over on Twitch, it would be great, but most of you are not on Twitch, but I might even start doing a third meeting on Twitch. We'll see. Let me just do one last thing here. So with the our only oral drug approved for IC, Elmeron, now known to cause retinal disease and in fact blindness in some patients. We are now working with patients who are legally blind, which is a tremendous tragedy. Patients are wondering what their next option are, and there is no other FDA-approved medication that provides a bladder coating effect. So you've got a couple of ways to go. The first thing you could try, if you've got estrogen atrophy, you've got a chemical injury to your bladder where you need that little bit of an extra coating, you can always ask your urologist to do some rescue installations, heparin, lidocaine. They can even teach you to do that at home, so that you can do that at home. And there are some people who do that at home. The other way to do it is with a chondroitin-based supplement. There was a research study released at the European Society for the Study of IC earlier this year that found that chondroitin was the most effective at restoring the integrity of the bladder wall. And of course, that was for installations. It was comparing chondroitin with hyaluronic acid and other things, but it's the chondroitin that's the active ingredient. So the nearest that we have to that, since that's not approved in the United States either, is a chondroitin-based supplement. We believe that the chondroitin can help provide a little bit of an extra protective coating. And patients have been getting off of Elmeron and transitioning over to chondroitin-based supplements for 15 years now because Elmeron got so expensive. So this is something that we have seen for years, patients able to transition successfully to other supplements. I mean, to a chondroitin-based supplement. And so the supplements that are really the options right now are going to be, whoops, I'm missing one. Where, here it is. All right. So the supplement that first became popular, I mean, for 15 years, Cystoprotect. Cystoprotect contains chondroitin and hyaluronate with quercetin and an olive oil base to help it be absorbed more easily. As Cystoprotect was created by IC researcher Dr. Theoharides, federally funded IC researcher who was doing some research for the state of Massachusetts on the safety of supplements. As he was going through that research, he went, I wonder if this might help IC. And so he followed his gut instinct and almost 20 years ago created Cystoprotect. So this has been around for quite a long time. Our challenge is we've learned more about IC since this was developed. And because he has a non-compete agreement, he is not allowed to create another supplement. And so, and one of the things we've learned very specifically about IC, and I talked about this earlier when I was starting this meeting, now almost 4 hours ago, is the importance of nerves and how do we calm nerves down. So the next supplement that came along about 6 years ago was Cysto Renew. And Cysto Renew still has the chondroitin base, quercetin, for the antihistaminic effect. But Dr. Gio Espinosa, who runs the integrative urology department at New York University in New York City, what he did is he added a couple of more ingredients. He added a little bit of aloe for the soothing effect of the aloe, but he also added lemon balm, and lemon balm is known for calming nerves down. So this was the first supplement that also tried to target nerves. And quite a few Cystoprotect patients switched to Cysto Renew, and they loved it, felt it was better, but then other people preferred Cystoprotect. Now, 2 years ago, we decided, it's something we're always talking about, I mean, because so many people are struggling. And I've talked about this just before. A new company came forward with a CEO who actually had severe pelvic pain from being injured by a surgeon. And he was so traumatized by the intense pain he experienced that he decided to see if he could redirect some of his assets into working with the science, because he already was making a number of other kind of protein shakes and he'd worked with kidney issues. And so Natural Approach Nutrition stepped forward to try to create something very new and different. And their first project is Bladder Builder. And this right now is, in my opinion, the best supplement on the market. And I'll tell you why. So it has all the critical active ingredients. So it's got the chondroitin for the bladder wall. It's got quercetin for the antihistaminic effect. It's got, here, hold on a sec. I don't have my right glasses on. He's got collagen in it for the bladder wall. He's got some beneficial probiotics for the gut, because that's our own MAP Research Network, National Institutes of Health Studies, continue to find that our biome is a bit messed up. So he's trying to support a good urinary biome. But the most important ingredient in this is palmitoyl ethanolamide, also known as PEA. Now, why is that in there? Because last year at the American Urology Association conference, the Italians brought the first IC-PEA study to the United States, and it was stunningly good at reducing pain. So PEA has been used for decades in Europe for chronic pain. It's been studied with sciatica, with fibromyalgia, with burning mouth syndrome. You go over to pubmed.gov, you can read through all those research studies. And I've known about it. We've had pharmacists in the United States trying to import this for IC patients for about a decade, but it was always really expensive. It's thousands of dollars. And so, anyway, the Italians, to everybody's surprise, brought an IC-PEA research study to the big national conference. And the results were stunning. The results showed, now these were patients not responding to any other therapies. And at month 3, 87% of patients had a significant reduction in their pain. At month 6, 25% of those patients were pain-free, and we saw, again, improvement. So the doctors at the conference got really excited because they don't want to give opioid pain medicine anymore. Sorry, hold on. My mouth is dry. So, to be able to have something that might take the edge off pain, if not eliminate pain, it's not an opiate, created tremendous excitement at that meeting. And the doctors were just thrilled. And so I told Natural Approach Nutrition about the study. I sent it to them. And I said, hey, why don't you see if you can find some PEA? And by golly, they did. They did. And it's affordable. And so this is the first comprehensive bladder supplement that not only supports the bladder wall, but it also supports pain relief. So we just did our 1-year follow-up study with this, and I published the data on our website and a blog. So, supplements don't work for everybody, right? And so, we wouldn't expect that to be the case. So we emailed a couple hundred patients who were using it, and 59% of those patients were still using it and they liked it, and the rest had stopped. And we asked them why they stopped. And number 1, it was cost. They just couldn't afford it. Number 2, the doctor wanted them to try another treatment. Or number 3, they had a side effect. And the side effect is very consistent with all the supplements. Any chondroitin-based supplement or aloe supplement is known for causing a little bit of stomach distress in some patients, right? Okay, so we know that basically 40% of the people stopped using it. But of the 60% who continued to use it, the results were wonderful. That literally 25% of patients using it were reporting no pain anymore. They were having fewer flares, they were having shorter flares, and they were having less painful flares. And so it was a shot in the dark to see if PEA in a chondroitin supplement would be helpful. And based upon that early study, and granted, it's not a super scientific double-blind placebo-controlled study because that's extremely expensive, but this is a viable option. The actual formula in the study did not contain chondroitin. It contained palmitoethanolamide and resveratrol. And so what they did is they created the American version of the study formula that we're calling Peora. And so this doesn't do anything for the bladder wall, but it might help calm nerve pain. And in fact, when people ask me what I'm doing, this is what I do, because I am a central sensitization patient. Not every night, but if I start feeling those random needles in my skin, That tells me when my nervous system is getting amped up, and that's when I'm going to go to something with PEA in it. And of course, we have allopath, aloe with PEA in it too. For patients who are super sensitive, and or if you flare when you take a probiotic, they also created a really streamlined formula called Bladder Rest. This is a much simpler formula for people who are more intolerant. And so Bladder Rest is a viable option too. Like for me, because okay, so I used to take Sister Protect, and what we always tell patients, when you're trying something new, don't take the full dose the first day. For God's sake, don't overwhelm your body. You have to kind of just take one pill and see how you do, see how you feel. And then one pill a day for a week and see how you feel, and work your way up slowly. Which is, basically the strategy for people who are sensitive anyway. If you're like me, I hate taking new stuff. It freaks me out because I have reactions. So I took one Sister Protect and it was fine. It was fine. I took one a day for a week and I had no problems with it. But when I went up to 2 a day, it gave me loose bowel. So when I took Sister Protect for, off and on for a couple years, but I never took more than one a day. Never took more than one a day. And that's because of my sensitive redheaded Norwegian body. And so with Piora, I'm the same way. The daily doses too, I only take one and I don't take it every day. I come from a less is more perspective. Now, of course, everybody is unique. What works for me would not work for you, vice versa. It's about trial and error. What I can tell you is that the American Urology Association, in their IC guidelines, list supplements in step 1. They want you to try supplements before you try things like Elmeron, because the supplements carry less risk. The AUA guidelines, 6 steps of treatment. You start at step 1, you do everything in step 1 before you go to step 2, and vice versa, and you work your way up. And it's all about putting your safety first. And so it's not me saying, hey, supplements are viable. It's the American Urology Association who's saying the supplements are viable options and they're reasonable to try because they carry less risk and they're not invasive. But they don't work for everyone, but they are at least options for you. And so there you go. You've got other options if you're IC subtype 2 bladder wall driven. If you've got pudendal neuralgia, you're IC subtype 4, and we know your nerves are involved, or if you're IC subtype 5 central sensitization, then doing something with PEA makes more sense, because what the research shows is PEA seems to be pretty good at calming nerve-driven pain down. So, it's kind of targeted. What you don't want to do is go to a health food store and say, hey, I got a bladder problem, and have them recommend stuff to you, because they don't have a clue. And the odds are they're going to be giving you something with chondroitin in it, or something that's very irritating. So Julie says, what about D-mannose with cranactin? D-mannose is not viable for you, Julie, because you did not test positive for E. coli. D-mannose works because it can bind to cells on E. coli, which prevents them from attaching to your bladder wall, and it washes out. So D-mannose is only effective for the prevention, not the treatment, but the prevention of E. coli-based bladder infections. Julie says, what about Metagenics, the ultra-floral probiotic for women? You know what? I have heard about that, and I know that we have had other patients talk. I have to look at that again. Hold on. Let us see here. So it would be under women's health. No, I'll look under probiotics here. So the Ultraflora, is that the one? Oh yeah, they just have a ton of info. I mean, it's just going to be a trial and error, hun. I mean, you can give it a shot. Just go slow. I mean, if your doctor suggested that you try a probiotic, then that's certainly a viable one. Teresa says, would I have to finish bladder installation therapy before I can start hyperbaric oxygen therapy? I've had 4 that you have multiple Hunner's lesions. So, hun, bladder installations are not a treatment for Hunner's lesions. I don't know why they're doing that. Hunner's lesions require lesion-specific therapy. And the AUA guidelines very clearly say that. So lesions are treated. I mean, there are 2 theories behind Hunner's lesions. And, you know, hold on a sec. I have pictures here. Let me. Ooh. Oh, I should show you guys that picture. It's such a creepy picture. Where is my lesion picture? Where is it? Let us see if I can find it. Microgen. Where did it go? Uh-oh. All right. Well, lesions are profound red areas on the bladder wall that often bleed. They bleed so much, it's called a waterfall effect. Okay. And so there are 2 theories behind Hunner's lesion, and there's probably more. Okay. But, you know, patients with lesions, when you biopsy the lesion, there is a war happening. There is massive inflammation inside those lesions. And there's a massive denudation or damage or change of the cells of the bladder wall. And that's only seen in Hunner's lesions. That is not seen in chemical injury or anything like that. So it's and that's why around the world now Hunner's lesions are being very quickly put into its own disease group. Everybody now understands that Hunner's lesions are a separate and distinct disease as compared to the rest of us. For those of us with pelvic floor, et cetera, or even chemical injury to the bladder wall. So Hunner's lesions, we know, do not respond to Elmiron. They do not respond to typical bladder therapies. We've known that for decades. It was the European researchers who made a very interesting discovery, Teresa, and this was 5 or 6 years ago, when they found in the urine of Hunner's lesion patients a virus, the polyoma BK virus. And it's quite interesting because, again, they tested other patients and without lesions, and they found nothing. And then there were a couple of more studies that continued to find lesions. I mean, continued to find viruses. So they found the Epstein-Barr virus, and then HPV was talked about to a certain degree. But really, it was the polyoma virus that was the most shocking, right? And so Europe, you know, they've been on this. The Europeans are really very invested in subtyping. And so as we were getting these viral studies, the Americans were saying nothing. And it's like, guys, this is big. I mean, this is big. And what I didn't know is that the Americans had also launched their own viral study as part of the MAP Research Network, where they had, for hundreds of patients, urine samples over time that they were saving. And they published the data for that. I might have been presented at AUA this year. Anyway, the data was just released. And what did they find? The polyoma virus in some IC patients. a small percentage, and that led them to believe that some of us, patients with lesions, have a chronic viral infection, which really changes everything, right? Because if it's a viral infection, then the next step would be using an antiviral medication. So this helps us understand why Hunter's lesion patients never responded to Elmeron and wouldn't necessarily respond to a bladder installation if it's a viral infection, right? So that's very exciting. And again, the MAP Research Network data, you can email me, Teresa, or give me a phone call, and I can find that for you so that you can give that to your doctor. And it would be really good to have a next generation DNA test that will do a viral scan, just out of curiosity, right? Because it's data. The second theory about a Hunter's lesion is that it is a nerve that is just massively inflamed, just massive neuroinflammation. And when nerves are massively irritated, they release something called substance P, which damages tissue, which could cause the lesion. And so therapeutically, lesions are treated in basically 4 ways. Number one, they're going to cauterize it, or laser therapy it, or fulgurate it, where they're just basically burning it. And what does that do? That kills the nerve, and or that kills the nerve that the virus might be living on. So that's concept number one. Concept number two is to inject a steroid into the center of the lesion. And that, what that does is that calms the inflammatory part of it. And so that is considered equally successful to cauterization. But the nice thing about the steroid is that it doesn't leave scar tissue, whereas if you cauterize the bladder, you leave scar tissue in there. The third way of treating it is with hyperbaric oxygen therapy. And that's where you go into an oxygen chamber. It's basically a room at a hospital. They use it for a lot of wound healing, burn victims, where they increase the oxygen in the room, which pushes oxygen into your bloodstream, which then delivers the oxygen to any tissue that's damaged. And so we've had a couple of research studies. I featured it in our magazine last year, which have shown that hyperbaric oxygen therapy was remarkably successful at reducing Hunter's lesions. And the last one, unfortunately, is not available. It's called Liris, L-I-R-I-S. Liris is known as the lidocaine pretzel. And the Liris story is really important because it was created at MIT about 15 years ago, 10 years ago, somewhere in there. And they were trying to find a way to deliver medication to the bladder over time. Because the problem with treating the bladder is, how do you get medication to stay in the bladder? Because you pee it out and you cannot hold your urine for hours at a time without damaging your urine. So what the researchers at MIT created was, it's like a noodle. It's like a hollow piece of plastic, but it's like a noodle that you put medicine in. And so they put it in your bladder, and it kind of contorts on itself. They call it the lidocaine pretzel, because when you put it in the bladder, it kind of bends and folds, so it shouldn't come right out. And the way it's built is it allows for time release medication. Now, the first medication, so their first intention with it, because this is going to revolutionize everything. I mean, this could revolutionize UTI treatment. This could revolutionize bladder cancer treatment. But their first goal was to reduce pain. So what they did is they put lidocaine in it, which is a numbing agent, right? And in their very first clinical trial up in Canada, I was like 12 patients, half of whom had Hunter's lesions and half of whom didn't. And what do you think happened? The lesions disappeared. They healed. 2 weeks of Liris, and every single lesion healed. And they were stunned. And I had a phone call from one of those patients, and she was ecstatic. She goes, "My lesions are gone." And like, "How?" She goes, "I did Liris." I go, "What's Liris?" She goes, it's a new thing. So I called the company that makes it, talked to the CEO. He explained it all to me. And we couldn't talk about it for a year. I had to wait for the data to be published. And when the data was published and presented at the American Urology Association conference, the language they used to describe the effect of Lyris was a complete and total resolution of the lesions. They were stunned. They were mind blown. How could this happen? The worst form of IC healed in 2 weeks with this Lyris device. So then they did more studies because they were on the pathway of having for it to be used for pain. And in every subsequent study, lesions healed, or the number of lesions reduced, or they got smaller. And so then Allergan came along and bought the device from the company that had it. Now, Allergan is known for Botox, right? They decided to repeat all the studies, which they did. And we all got very excited that here we had the big bucks, big pharma, who had the device that could cure the worst form of IC. And what do you think happened? They deprioritized it 2 years ago, and it's sitting on the freaking shelf. They're doing nothing with it. And it is so sad. And so we did, it was either last year or the year before, we asked patients as part of IC Awareness Month to send them emails begging for them to try to get this through the FDA approval process so that it could ease the suffering of the millions of patients, or hundreds of thousands of patients with Hunner's lesions. And it is shelved. So Teresa, Hunner's lesions require lesion-specific therapy. So we're talking cauterization, laser therapy, fulguration, steroid injection, or hyperbaric oxygen therapy. That's how you treat lesions according to the American Urology Association. The bladder installations, we have long known, have not been particularly helpful, although they might reduce some of your pain. And there's nothing worse. You know, when people call our office and they're crying in pain, we're really trying to figure out why they're suffering to the degree they're suffering. And what we consistently find is that they have Hunner's lesions that have never been treated correctly. When you treat the lesion, the pain improves dramatically. And so come on over to our website, icnetwork.org, read our section on Hunner's lesions, or you can go over to the American Urology Association website, auanet.org, and go right to the IC guidelines. In the upper right-hand corner is a link that says guidelines. Go to the guidelines page, search for interstitial cystitis, and you can read the studies there in the IC guidelines. They have Hunner's lesion therapy treatment in step 3, although they say as soon as lesions are identified, they should be treated. All righty. All right, guys. Hey, man, you didn't expect a history lesson, huh? How do we get a next generation urine test? Jennifer, go to bladderhealth.org, bladderhealth.org. That's a website that I built a couple years ago, and that gives the contact information for Microgen, and you can just call them. You pay for the test. Unless you're trying to use Medicare, you just pay for the test. They send you the test. It's the amount of urine they need is tiny. It's like this amount. It's a tiny amount. They give you a way to collect it. They teach you how to do that. Then you have your doctor sign the form. You can have your primary care sign the form. It shouldn't be an issue at all. And you send it back to them, and you'll have results within a couple of days. If you want to have a virus tested, you might need to use a different company. I don't know how much Microgen does for that. All the next generation companies are also now doing the COVID testing. So, yeah. Susan says, my urogyno has done tons of tests CAT scan, MRI scope, urodynamics, and has no answers for me. Says probably not IC, but not sure where. That's why I'm asking for a doctor specialized in IC. So Susan, if you're willing to travel, number one, please come to our website and at least watch the video, the 5 subtypes of IC, so that you understand the diversity in this patient population, because it could be anything at this point in time. We have to rule a lot of stuff out. On our website, I have a whole list of confusable diseases. I mean, if you've got a Tarlov cyst off your spinal cord, that could do it. If you've got fibroid tumors, if you've got scar tissue, if you've got a broken tailbone that's bent out of position, if you've had any other major pelvic traumas, any of that could be the result of this. And I would be happy to talk with you by phone later this week. I take Mondays off, but if you want to call Tuesday afterwards, feel free to call our patient assistance line, and maybe we can go through your history and see if we can find a suspicious event that might have led to this onset of this. And then, if for really, really complex cases, you're probably going to have to travel to a national doctor. So it depends upon where you live. If you're in the Midwest, it would be Ken Peters up at Beaumont, with the top IC research center in the nation. He has a fabulous team, state-of-the-art urology department there. If you're on the East Coast, you could go hit Robert Evans, who's the IC Doctor of the Year 6 years in a row for IC Awareness Month. Or you could go see Robert Moldwin up in New York. Those are really the top 3. If you're out on the West Coast, you could go see Christopher Payne at Vista Urology in San Jose. You could go to the University of Washington, or you could go see Dr. Phil Hanno at Stanford. There are options, but some of your cases are very complex, and you've got to walk away from the local doctors who don't have the expertise to go to those regional doctors or those national doctors. Jennifer on YouTube says, oxalates, any feeling? Oxalates are strong, sharp crystals. And this actually, my dear, boy, you just led me into, I want to show you guys a really interesting picture. Look at this picture. These are crystals that are literally growing out of this bladder wall. Look at this. So this happened to a patient who, this was not an IC patient, as a matter of fact. This is a surgical malpractice patient, and he's had 13 surgeries now to try to correct the damage done by this original surgeon, who is now in jail because many, many patients were harmed by this one doctor, I think in the state of Utah. Obviously, he's lost his medical license, anything. So in this case, this gentleman contacted me and was in deep distress, and I've been helping him for years. Well, like 2 years ago, they went in and they were again trying to restore damage done to his prostate, and they left a bleeder in his bladder. And so his bladder, they sent him home. They had no idea that his bladder was bleeding, and his bladder filled up with blood clots. Just imagine jelly. And he couldn't pee, and it was an emergency. They get him back to the hospital. They realize fairly quickly what's happened. So they sent him right into the OR. And as the doctor is, and he's got a big belly incision, his life was at stake. They open him up, and as they open him up, his bladder ruptures in 2 pieces, and all this blood comes flying out, right? I'm not lying. Now, this is not an IC patient. Y'all don't need to worry about this. Now, this is an example of weird things that happen. So they had to sew his bladder back up together, 2 pieces back together. And when the bladder is severely injured, it sometimes disrupts a calcium metabolism pathway. And when that happens, the calcium grows out of the bladder wall. And that, my friends, is a bladder stone. And he had hundreds of them along this surgical site. See, you can see it's here. So they have to go in and remove them. And it took 3 or 4 times, but they finally got them to stop. And his bladder is healed and he is much better. But anyway, so you asked the question about oxalates. That's an example of a bladder stone that's made of calcium and oxalate. But I see patients, most people that doesn't happen to. That happens in the face of really, really severe injury. Foods, oxalates are crystals. They're sharp suckers. They're sharp little structures. And they, because they're crystals, they collect together and then you end up with stones. You end up with stones with very, very sharp edges. And these stones also become a host for a lot of bacteria. So these kidney stones that are calcium kidney stones are just covered with bacteria anyway. And because it's a crystal, it's irritating. It cuts you as it's coming out of your body. Even though it's microscopic, it hurts. So many IC patients find that reducing foods that contain oxalates to be helpful in reducing pain. So that's going to be berries, spinach, chocolate. So trying, but this is not everybody. This is a small group of patients. But if you're oxalate sensitive, then it's okay to lose the oxalates. I don't eat chocolate. I don't eat spinach. I do eat berries, and I've never flared from a berry, but it's interesting to try that. Good luck, Jennifer. I hope it does. I hope it does. All right, my friends. Well, listen, it has been a wonderful day. We're at almost 5 hours and counting. We're 15 minutes short of 5 hours. I'm going to leave you your homework every day. Every day, I need you to do 15 minutes for your spirit. We got to calm your body, calm your spirit, give yourself some comfort. However you choose to do that, whether it is lying in bed and reading a book, or whether it is going to church or listen or meditating, do something every day to calm your spirit. Because remember, when you are stressed, your body is going to interpret pain more aggressively. For 15 minutes a day, I need you to knowledge about IC. For God's sake, read a blog. Come to the website, go to websites, read it. The 2 websites that I think there are 3 websites that I really like. Obviously ours, because I write it, and it is rated number 1 by Harvard and the University of London. So ours is a good place to start. You can go to the ICA website. And pelvicpainrehab.com is, in my opinion, the best website on pelvic floor disorders. So would you just read something? I mean, come on, 5 minutes. You can do it. I need you to do something for your body every day, whether it's your pelvic floor work, your internal massage, or stretching, or following the IC diet, 15 minutes a day. That's not asking too much. Self-help is the foundation for success. Man, if you're not following self-help, you are making a mistake, because it is how successes are built. And last but not least, what I really need you to do is I need you to laugh, because laughter will help your brain interpret pain and discomfort differently. And so watch funny videos, funny TV shows, but come on, got to get your humor up there. Get out of your bedroom, open the drapes, let the sun shine in, talk to people, and let's turn on. You know what? My favorite song right now is BTS's Dynamite. Oh my God, I just love that song. Let's bring some life into your house right now and move a little bit, and let's focus on the future. Healing is always happening. Remember your affirmations. Repeat positive things to yourself every day. I can do all things through whatever faith you have, which strengthens me. Every day, in every way, my life is getting better and better and better. That which is done for you, let it be done. That which you must do for yourself, do it. Give yourself positive messages. Every time you have a negative thought, visualize a stop sign, close your eyes, visualize the stop sign, take a nice, slow, deep breath, and then remind yourself it has no power, and replace it with something good. This is going to be a great doctor's appointment. We're going to figure it out. This is going to be a great physical therapy appointment. My God, it was my obturator muscle. This is going to be important. This is going to be meaningful. Don't assume it's going to be bad. The one thing you can count on is that healing is always happening. The problem is you don't know what's hurt. And that's our first goal. We can't have good discussions about treatments until we understand your anatomy. And it begins with you knowing what your anatomy is. Like read a freaking book so that you understand these very complex structures in here. Look at this. This is a small cavity. There's a lot happening in this pelvis. I mean, look. Hold on. Wait, where's my levators? Okay, so hold on. Let me show you this so that you can really see this. Okay, so I just put on the levators, right? Now look at, this is a small cavity. And yet it has to have, for women, a uterus and ovaries, right? It has to have a bladder, right? Right? There's the bladder. Well, hell, it's got bowel in it. So we got to stick the bowel in here, which is not easy, right? You see how quickly this is filling up? And this doesn't even include the blood vessels and the nerves. And this is where Western medicine fails because doctors like to stay in their box. Urologists like to stay in the urinary tract. OBGYNs like to stay in the reproductive tract. Gastroenterologists like to stay in the bowel. They don't necessarily understand interrelationships, and they really underestimate the role of the muscles in influencing all of those. And that's why you have got to learn about these things so that you can talk to your doctor. I always say, please don't walk in and say you have IC. That is a huge mistake. I need you to walk in and describe your symptoms and say, doctor, I am here to try to understand why I have this symptom every month. So when I sit for too long, my leg starts to vibrate. That's me. That happens to me because I have a pudendal neuralgia on my left side, right? Okay. Or doctor, when I wake, I have let's see, I sleep well, but as soon as I get up in the morning, I'm in the bathroom all day. Or doctor, my pain isn't just inside of my body, it's on the outside of my body. Your ability to describe where the pain is begins all of this. You cannot say it's down there. No, that doesn't help. Where down there? Is it by your rectum? Is it by your urethra? Is it by your vagina? Is it by your testicles? Is it by your scrotum? Where? And then also I want you to be able to say what makes it better, what makes it worse. What's the quality of the pain? Is it sharp? Is it dull? Do you feel like you're being cut or do you feel like you're being shocked? You are an anatomical mystery to be solved. And most importantly, remember to tell the doctor about traumas. Were you in a car accident? Did you have a baby that was a difficult delivery? Did you have a fall? Those traumas are critical to solving your puzzle. You got to give them the full history here, right? So don't drop down the IC hole and say, hey, I got IC, because you're just going to fall into their belief structure. We need them to neutrally study your body, right? Okay. All right, hon. Well, obviously I can talk about this forever, and I think it's time to stop, right? So I think you might see me this week. I'm trying to finish up this new IC book. So if I can, I'm going to try to come on this week, maybe Wednesday or Thursday. And hopefully you will see me back on Sunday, crossing your fingers, because life is a mystery and you never know what's going to happen. Isn't that the truth? All right, my friends, I will see you later. I wish you well. Come on over to our website. If you want to talk, icnetwork.org. You can find the phone number. I take Mondays off, but you're welcome to call Tuesday through Friday. I do first come, first serve. Sometimes you get me right away. Other times you might have to wait until that evening or even a day or two later. Okay? All right. I'll see you later. All right, my friends on YouTube. See ya.